allows such a breach of security? And remember, they'd also outsource, so it brings in another company, CallNet, and I'm sure they outsource a lot of other services. And it starts to question, should you be outsourcing, and where does the responsibility lie?
Is it
if you're
industry-wide
outsourcing?
Practice to outsource as well? You know, it also emerges.
But for some, where security is involved, perhaps outsourcing isn't the answer.
But Jerry, many people who actually report stowaways in other parts of the world, they haven't had issues that you are referring to.
Let's take a look at what's happening on the roads, and then you come back and continue with this conversation. Good morning. It's 27 minutes to 8 o'clock.
Traffic.
It's moving slowly on Mombasa Road in both directions, heading to and out of the city. All right, looking at Langata Road, we had some problems this morning coming out and then joining Bagavi Way was clear up until about half an hour ago, about 10 minutes ago. We've seen it escalate on Gong Road. The construction continues, but it's not so bad. Able to apply that route heading in and out of the city as well. It's actually not very bad today. Juja Road is actually looking very, very good. We still had problems on Thika Road today getting into the city. We had traffic right around the Allsops Junction. It is now at a standstill. But from what we see, all indications are that it won't be a terrible morning as concerns traffic. Everybody's left the city after the conference ended yesterday. And so, except for where there's road construction going on or where there are repairs happening, traffic is actually quite good today. Applause, applause. 0719-012-600 is the number to call if you see something out of the ordinary. Let us know. We'll share the word and keep you moving.
Mature, intelligent talk every morning. Spice up yourself. Mornings done right. 94.4 Spice FM, Nairobi.
A man fell from the sky aboard Kenya Airways flight that was heading to London from Nairobi JKIA. Since then, there has been a report aired by Sky News, and that report has elicited a lot of reaction. So, number one, Kenya Airports Authority has said the person identified in that story by Sky News as Paul Manyasi has never worked at JKIA. They don't have any records of somebody by that name, Paul Manyasi at JKIA. The Sky News reporter had gone all the way to Western Kenya and found a certain family. And this family, they were shown images and they said, yes, this looks like our son. And they were told then, we are sorry to be the ones to bring you this bad news, that your son died in the UK. Then later, after that story was published, KTN went and caught up with the family. And they spoke to the father. And this time the father, what's the name of the father again,
Isaac
Betty.
Who previously had told BETI.
Yes, Isaac Betty.
Yes.
Is the name of the father.
Yeah,
and this is what he said.
Jina langu naitwa Cedric Shibonja Isaac. Hiyo picha naona kwa mtandao sio ya kijana yangu.
Labda wale wanahabari kutoka Sky News walikuja kukuhoji lini?
Wiki tatu iliyoisha. Na niliwakatasha. Nikamwambia huyo picha ananionyesha na ile majina wananiambia huyo mtu mimi simjui, hiyo niliwakatasha.
Labda walipofika hapa walikuambia kwa nini wamefika, walisema kuna yule kijana amepotea na wewe ukawakataza.
Niliwakatasha. Nikamwambia kijana wangu ndiye hajaonekana kwa muda, lakini yale mnaniambia mimi siyajui.
Turudi jina lako na jina la kijana wako.
Majina yangu ni Isaac Betty. Yeah.
Na jina la kijana wako?
Kijana yangu majina ni Cedric Shibonje Isaac. Yeah.
Na yule aliyepotea unasema ni Paul Manyasi.
Unasema ni Paul Manyasi, huyo mtu simjui. Hata majina sijawahi kuyasikia hata kwa hii area. Yeah.
Labda walikuonyesha zile picha ya vile vitu walivyokuwa navyo, viatu, begi na nini, labda unavifahamu?
Niliwakatasha, sivijui, ingawa kijana wangu anapenda vitu vya sports. Niwaambia hizi vitu vya sports na naweza sema ni zake lakini sio zake. Ingawa anapenda vitu za sports.
This is interesting because just looking at the elements or the factors of this particular story and what he says, this was actually an interview that was done with him on Monday afternoon. Previously, interestingly enough, when he saw the same pictures and the same elements, he at that point had said his name was Isaac Manyasi. So now you start to see, and he is actually on record having said this, and just information that we've been able to get from the local journalist who went along with the Sky News journalist to the same place where now the wife was in attendance. So the conflicting stories, and unfortunately what happens is when this kind of conflicting stories come out to the fore, again you give fodder to people for speculation, because why 3 weeks ago or a month ago did he say his name was Isaac Manyasi? Why then did his name now change to Isaac Betty? And then why suddenly did he not know then 3 weeks ago that his son was in jail, was in remand, and then now 3 weeks later his son is in remand? Do you see whether what is true or not when you play it against what was said?
I actually don't see a problem.
Changing your name, not knowing that your son was in jail.
Those could all be his names.
He said Manyasi, he doesn't know who Manyasi is. He said it now. Of the most recent story is that he did not know what his name. He did not know who that person was. You see, but previously he said that is what his name was. So I mean, it's the back and forth, who said, who did not say kind of thing. And the problem with that is that once you hear something and then you hear something else, speculation then is rife. It happens, and it's very clear that now this is where we are. Everybody is now saying
there is the small chance, there is a probability that indeed this man is telling the truth. But on the balance of the facts we have, and if you look at it from circumstantial evidence, KAA and KCAA have given, first of all, contradictory statements. KAA had an opportunity to come out and actually verify the story with Sky News. They didn't. Initially, the parents accepted this. They were in mourning and admitted this was their son. They've now denied that. So once you start seeing these conflicts, I mean, intuitively, somebody's lying.
Let's get in touch.
Who is lying and who has a reason to lie?
Let's get in touch with the Standard Group's KTN reporter, William Lusige, who is the one who went to interview Mzee Isaac Shivonje at his home.
When?
And that was at
initially with the Sky News reporters.
No. Later on. This is this week.
William, good morning.
Good morning.
Welcome to the Situation Room, and thank you very much for joining us.
Yes.
Now, the first question is, of course, when did you interview this Mzee at his home?
The next day after the airing of the Sky News investigative piece, we wanted to find out the family, and then we were able to locate it at Malava in a small village called Mahwabuye. So we woke up the next day early in the morning, and we found the father in his homestead. But shockingly, when we got there, especially the Luya, they mourn when they lose their loved one, but the family was happy, just going on with their normal business. And when we got there, they were shocked when we told them that we saw on TV and even read on a newspaper that your son died as a stowaway in London. They said they had seen the pictures, but they had told the Sky News reporter that was not their son.
So when they saw the pictures, did they say that the son, the person in the photos resembles their son?
Definitely, they said that was not their son. We gave them the pictures from the Sky News, and even they gave us their own pictures of their own son, which was totally different. And then they said when they were asked if that was their son, they said they did resemble, but that was not their son.
So did they deny or confirm, according to what this story said? Because, William, from that story, obviously, which you read down to the fine detail, they saw the picture and they even talked about how, even if we're going to bury him, it's too expensive. Let him just be buried in London. After all, soil is soil. And the mother actually shed tears, and she said, yes, she had not seen her son for 3 months. And she now said, okay, well, it's too expensive. She would have preferred that he be brought home to be buried, but obviously something of the cost is not what they would be able to manage as a family. So if that's what they would... Did you talk about this with them? Did they say anything as to that, or did they deny that they actually said anything like that?
We talked with them and they denied, saying that we even had to play that clip for them, but they said they denied that that was not their son. What they did, they said, first of all, that stowaway, as it was indicated by Sky News, was called Paul Manyasi, but their son was called Centric Shivonje, and then their names, the father said is not called Isaac Manyasi, he's called Isaac Betty, and the mother said she was called Janet Shivakala Isaac. So we asked them to provide evidence that what was quoted by Sky News was not the real name of their son, and they provided documents including a birth certificate, which even showed that the Sky News had said their son was born in 1991, but the birth certificate clearly indicates he was born in 1994, and the name is not Paul Manyasi.
Could they have more than one son, perhaps?
They have two sons.
Right.
The second one is a candidate next year. He's in Form 3 currently. Yeah.
Could they have three sons?
And they don't know of-
how
and
did
they
you
don't know
manage
of
to
one.
locate these guys? If this is not their name as reported by Sky News, who were you looking for when you went into this village?
It was difficult, first of all, to locate them because they come from an interior village. We started asking because they had said from the story that the family came from Kakamega. But when we checked the footage, we clearly see a small market at Malava. Then we went all the way to Malava. It took us around 4 hours to identify the family. We asked, and then finally we were able to find it.
Who were you asking for? Were you asking for Isaac Manyasi?
We were asking for Isaac Manyasi, but the residents of that small village said they only know Isaac Betty. And when we went there, he confirmed that he was the one who was...
There's only one
interviewed by
Isaac
Sky.
in that village?
They were showing the image.
Definitely.
William, I assume that when you went to that market, you were showing them the image of the man in the interview in the Sky News story.
Yeah, yes.
And
No,
that's-
you're giving him you're giving him answers
Because
here.
he said that
No,
already
he's not.
previously. I'm a journalist. I know this is obvious. What when they say this is how we identified. So the person who you were sent to confirmed that the Sky News journalists had been to their home.
Even the neighbors confirmed that.
Even
too.
the neighbors confirmed that. Now, did the journalists, did the Sky News journalists ask for further information like what you asked for, like identification, ID, birth certificate, anything?
No, he did not ask for that.
The Sky News journalist did not request this information from them?
Yes, he did not request.
Have you tried to
actually,
reach...
they gave him one. Okay.
They gave him what?
They gave him one of their son's picture, which was also used in his story. And that is the same picture they showed us together with others. They said that they gave him that picture and said, this is not our son. Yes.
Have
Did
you
he-
tried to reach the Sky News reporter, the correspondent?
We have not been able to get in touch with him because we don't even have his contact. But maybe to say something, I think there's someone who is lying between these two stories. Maybe the family, yes, or maybe the Sky News. And if they did the assignment well, then who lied to them that name Paul Manyasi? Because they began their journey from Nairobi all the
Looking
way to
for
the
Paul.
With the name Paul Manyasi.
Yes. So what happened along the way? Who told his family? Initially, they accepted that their son was called Paul Manyasi. Then why they change a few
Why
days
did they
later?
change the story? I want to ask something that is actually, in terms of what has developed over the last days, that now we have Isaac Betty saying that his son is actually in remand in industrial area remand prison. But of course, also coming from a journalistic perspective, why then did this particular piece of information did not come out? Why did it not come out about a month ago when these questions were being asked? Can it be that he only found out that his son was in jail 3 weeks ago, or 2 weeks ago, a week ago?
He said he had found out that 2 weeks ago, and we even followed up with the people in charge of Nairobi Industrial Area Prison. They say they do not have anyone in custody with that name, but the father was supposed to actually to travel today on Friday to Nairobi. So I think it's better if the story will be followed much from the other side. And apart from that, another point was that the stowaway fell from the London plane on 30th June, but Cedric Page was still posting information and pictures, which is Facebook page, even on 17th of July, more than 17th day after the incident.
This is what I'm saying. Do you think they could have three sons? So Cedric does exist, and he might be in remand in Nairobi, and then they've got their son who's
their
about
other
to
son,
sit his
Paul.
KCPEs, who's a candidate, and then you've got the guy, the stowaway. So that they could have 3 sons.
I don't think so, because for the family, the other ones are very young. They will have only 2 sons. The one that they were saying is Cedric, and the other one is the one who is the candidate come next year.
So because they're young, they can't have an older son or 3 sons? What's your reasoning there?
Because we spoke in secrecy with the neighbors, and they even confirmed that the son of this family is called Cedric, and the other one is the one who is the candidate. So I don't think the whole village can lie, but it's still a good discussion point.
Yeah. You went through great lengths to find this family. How far have you gone in trying to locate this guy?
The son?
The Sky. The guy from Sky, the correspondent from Sky.
We had tried to get in touch with them, like write an email, call them. They didn't pick our calls, but we wanted to get the contact of Sparks, who was the reporter who did the story, and maybe get a clear picture from his side, but we have not been able to. And then the family was also requesting to have a DNA, which I think might be the final conclusion about this case.
Sure.
So the family has actually requested to have a DNA done.
Yes.
Why?
With who? Who have they requested?
No, why would you want a DNA done? Your 2 sons are alive. You've been told some stranger, according
and
to
you
you,
said
has
it's not
died.
your son.
You
So
said
why
it's not your son.
suddenly DNA?
Why would you request a DNA?
Obvious thing, Jerry.
Because
They
they were
haven't seen their
investing
Cedric.
But
No,
they've been told that
they-
Cedric is in industrial
They
areas.
haven't seen him.
No.
So
See,
you see
they know where
speculation
Cedric
again.
is.
They've been told Cedric is in.
And
is
Cedric
in
has
command.
been posting
Have
on
they seen him?
Facebook.
Have they seen him?
Cedric has been posting on Facebook.
Have they seen him?
Do you see?
Yeah.
So,
Have they
William,
seen
for
him?
you also, it's clear that definitely there's some kind of confusion here. Somebody is not being honest at some point. We don't know at this point whether it's coming from the family. We don't know whether it's coming from the Sky News reporter, as it were. We don't know if there's some kind of cover-up that's being done by KAA. The sister brother organization here, KCAA, says that KAA should have actually been able to sort out any kind of security lapses. So we even have blame between two transport agencies who, for them, are saying, look, somebody somewhere is not doing their job right. Isn't
Or
it?
is lying.
Or is lying.
Yeah.
Let's go back to this requesting for DNA. What could the reasons be?
Because the family is still insisting that this is not their son is still alive. They said if the government still insists that the stowaway was their son, then the only solution they think is to conduct a DNA to prove that that is their son. But for them, they believe their son is still alive and is being held at the industrial prison.
Okay,
Yeah.
so there could be an emotional shock and denial, perhaps, if the
Leading us
if
to
as far as they're concerned,
William,
they're,
thank you very
they're
much for
telling the
joining
truth.
us this morning. Asante sana, William.
Thank you
Wish
very
all the
much,
best.
William.
Okay.
I still go with this that, once we come back to looking at, even if we just want to focus on, take away our attention from the stories of the back and forth of who said what and who did not say, there's something that says that you tell your own story before somebody gets the chance to tell it for you. And KCAA or KAA had apt time, opportune moments to use this information that they had, or as you say at some point, did not have, to say this is our position at that time. Because like we said, on June 30th, when this information was made public knowledge in terms of what happened, they had an opportunity to be able to say, this is what happened. If there was a lapse, this was on our part, but this is what the story is. But then to refuse to give any kind of information until after the story has run and then come in denial mode, it then causes room for a lot of speculation.
Is KAA a government institution?
It is.
It's a state agency.
How do government institutions respond to such issues normally? Are they doing something that we've seen before, or are they diverted from the norm?
Well, this is definitely something that we've seen before. We're taking another opportunity to say that it should not be so.
And
because
why would
oftentimes
we-
we say, well, no comment because we don't want to deal with it. And in the background, what we're trying to do is put all the pieces together and then present a front that we hope then will be believed by people. But in this one, it's clear that they're trying to mop up what has already been
Have
spilled.
we ever had a case where KAA has reported a stowaway? No.
Why didn't we investigate this ourselves? Why are we waiting for Sky News and the Brits to do this?
It's true. This is an
KAA should have
indictment on
actually
Kenyan media.
KAA should have looked into this
KAA
before
has-
anybody else.
KAA is saying that they have been conducting the investigation. Of course, you expect that KAA
Then what are the
and Kenya
results of
Airways,
their
they
investigations?
still don't have a result.
considering in
They
terms
still
of
do not
proximity
have
to
the answer to
They're
who
still
boarded this
focusing on the
plane.
fact that this individual
They
was not
don't
the
have that.
employee. And that's the depth
No,
of the
this
investigation.
particular. No, come on.
That is what has been made public, and so that's what we're going to make inference on.
Eric, if you're to look at the facts, if we take what has been reported as the facts, you actually get the impression that KA is looking for an opportunity to deny that the person who actually fell was not even Kenyan.
You will
It's
hear
possible the person was
another
not Kenyan.
conspiracy.
Maybe
will
they
come
were
out that we don't
Nigerian,
even know.
no?
You see now?
Like you said,
Do you
No,
see what
since we can
KA has
throw
done?
the,
It's
wild
possible.
conjecture
Spin it
anywhere with no
we want.
basis.
They could even be Nigerian.
Yeah, probably
it's
Nigerian.
possible, yes, that this person actually had come into the airport through another flight.
Yeah.
And
from
what
another
come
country.
out
You see
into
now.
that?
Come out
How
into
does
that,
anybody get
this
into that
big one.
space?
Again, problem. You've gotten into a space that is restricted.
from
Restricted
another
access.
unsafe
Okay,
airport.
folks,
Restricted
what are the
access.
facts here? What are the facts?
Fact is, somebody fell off the sky.
Fine.
Fact.
Fact
And-
number 2,
He was male.
he was male.
He was black.
He was black.
Right.
Right? And the other fact is, there's an investigation that was conducted by
No.
the.
No, you don't know that. No.
It has been reported.
No, it has
there
been
are
reported that it was
investigations. That's the
investigation.
facts. Carry on.
Yeah.
Yes.
All right. So the police in London have reported that they are conducting investigations.
It has been reported that the police in London are carrying out investigations. Yes, carry on.
It has also been reported by KCAA and Colnet that they do not have an employee such as this on their KAA and Colnet that they do not have such an employee. It has been reported.
Not
It
such.
has no.
Not such.
It has been reported. They said
Somebody
they don't have.
called John Manyasi.
They said they don't have Paul
Somebody
Manyasi
called
on their
Paul
payroll.
Manyasi on their,
And then
not on the payroll.
KCAA came in and contradicted
And
that
KCAA
They
information
came
said
and
KAA
and
is
said
lying.
it's most likely that he
Guys,
worked here.
In fact, let's deal with this. The two statements by the two agencies. The Kenya Civil Aviation Authority said, well, in the case of such a stowaway, most likely, not definite, most likely that the person who actually has access to get onto a flight is somebody who works within the airport services. That has not been denied by KAA at any point.
Okay.
KAA has only come out to say, we have seen a report by Sky which says that the person who died in London was called Paul Manyasi. Now, we'd like to say we do not have any person who's called Paul Manyasi who works here. Or even Colnet, whom we have contracted, don't have a person like that we
Now,
have accredited
Colnet
to
is
access.
also on record by a lady for telling their employees that somebody has
That's
gone
not Colnet
missing.
on record.
That was KAA?
No, that is a lady.
A lady, yes. I said by a lady.
That's
right?
not Colnet on
It's on
record.
record. No, the fact that
It's on record
it's
that
on
a lady
record
said-
by a
An
lady.
allegation by a lady.
Yes, so it is
That's
on record.
correct.
It
An
is
allegation
on
on
record means
record.
it has been recorded.
An allegation on record by a
That is
lady who
fine.
claims.
No. Semantics, you're splitting hairs.
I am
My
not splitting
statement
hairs.
stands,
It is not
Eric.
a fact.
Colnet is on record by a lady. When I say it is on record, it has been recorded by a lady that Colnet spoke to them and told them somebody has gone missing. Let us not discuss it now.
Another fact is we do not have any evidence that the said lady actually even ever worked for Colnet.
No, even exists.
Well, we can try and find
We're
it.
going into
Why
the
don't we
paranormal.
do our
Yes.
own investigations?
We're going into the paranormal clearly
don't know
because now
the
we're dealing with
authenticity.
All this
possibility of
is
mystical
reported-
mystical
authenticity
features
of this
who worked at
particular
You make a
woman.
very
KAA or
good
worked at
defense
KAA.
lawyer, Eric. I'll
This
tell you
particular
that.
woman, yes, there's a woman.
Are we
and
even
have-
here today? Is there evidence that we're here, or are we imagining this?
I think today is
because
Thursday.
everything
There's nothing to show that the day has broken.
everything is being refuted, and there's a lady. Could be the same lady who says that this was her boyfriend and they worked together at Colnet. Now, if we can find this lady, I think it was the
We
nation
can
that
only
was
find this lady
this-
from the Sky Reporter. The Sky Reporter
No.
should produce his lady. Because he's the
his
one.
lady now?
He is the one who actually has come up with this
Let's
woman.
get hold of the
Nobody
Sky
else.
Reporter.
Even if we were to if we took the view that indeed this lady had a relationship with a gentleman who's passed away, it's very easy to claim all sorts of things
Yes.
about someone who cannot respond.
That we had a relationship with him. In fact,
guy isn't there.
in fact, we had plans. He was my fiance, and then a guy disappears, and you have done nothing. You have not gone to the police. You have nothing. You haven't even gone home. The parents
And you're
he's a
planning to
fiance,
get married.
and the parents don't even know you.
So, who is this Sky News? It's John Sparks. That's the Africa correspondent. Well, we'll get in touch with him over the weekend. I'll get in touch with him over the weekend. He'd be running a huge risk if he was making any of this
I
up.
have a huge feeling that this Sky report is going to fall off the sky. There are very many gaps that are emerging.
I'm looking at his
and we may
Twitter.
not be able to answer them.
You'd be
I'm
a very
looking at
good
his
spin doctor for
Twitter.
KAA also because then, they're doing exactly what they want people to do and take the attention off the fact that there is security lapse.
No, you doubt everything that you hear.
No,
especially when it
excuse
comes
me?
from the government. And
No,
this
I
is
don't.
wrong.
Actually, I don't.
Always
I don't.
doubt
No, speak for for yourself, but I don't doubt everything that comes out because I'm saying
And it's
I am
important.
saying the speculation is based on the fact that there
telling you,
is I'm telling you that the speculation is based on the fact that there is so much ambiguity around this. There have been statements and then there have been denials. You would only be
It's very important to doubt.
No,
It's
there would
very
only
important
be if
to doubt.
no.
Cast doubt on all stories that you hear
And
from
this is
all
why I
sides.
said
That's-
circumstantial.
and all of this is based on the fact that there is doubt. That's where we are coming from in the first place. There is doubt, and
so-
that's why we're having this. There is doubt.
So no
but
need
it is
to-
also shining
Why
the
you
light.
why are you getting
It is
emotional?
shining-
I'm
Not
agreeing
emotional.
with
Did I cry?
I am agreeing
it's
with you.
perfectly all right to get emotional, but
I'm
let me
agreeing
ask.
with you. Nunu. It's
is
okay.
it-
You doubt, and it's very okay. That is what you should
I
do.
am saying the
Which is
attention
why
is being
I am
you are
doubting
focusing
the
on
Sky
that, and I am
News.
Hey,
saying
you too.
the attention is being taken away from the fact
Control
that
them,
we are
CT.
looking at security. We are not looking at security, which is very, very
Yes.
important.
So, do
That's
me
what
and
I'm
you
saying.
believe this is a Paul Manyase guy?
Somebody-
KAA is covering up.
Somebody's covering
They
up
visited the
something.
parents in Kakamega, Malava, and they've actually paid the parents off. This is my genuine
Somebody's
belief.
lying.
They've paid the parents off to restructure their story. We also have another reporter that has been there, and the mother was mourning. The mother was crying about this. And the fact that I've also
was
asked for a
reported
DNA
that
test.
the mother
It was
was crying.
reported. All of this was that it was
we
reported.
have also heard from our reporter that we believe, because he works for the same organization as we do, that he
Speak
went
for
there-
yourself. No,
that
no,
he
no,
went
no, no,
there-
no. He works for the same
he went
organization.
there
But
and-
I doubt him. You said it's important to doubt
Yes.
Eric. So I
You
doubt.
doubt him.
No, I'm sure it's an honestly held belief, what
No,
he's telling
not
us.
belief.
It doesn't mean
he
it's
went
true.
There, he did not find any
Yes, but he
mourning
could have been
in this
duped.
particular village.
Yes, maybe the
And
finished
nobody-
morning,
no- nobody in that
17th of
neighborhood-
June. Or
Nobody in that neighborhood has spoken of any.
maybe they're
mourning
all in
recently.
cahoots.
Somebody's lying.
Maybe they're all in cahoots.
Somebody's
No,
lying. It's
How
very
is that
clear.
likely?
No, it seems like a
How
small
is that
village.
likely?
It seems maybe
All right,
KAA
all
paid
right.
off the whole village.
It's the top of the hour, and Jerry Thorne will get in touch with the Sky News reporter and give us a report on Monday, and then we will hear what happens. In the next hour, we're going to be talking about universal healthcare and the healthcare system in the country, and the the welfare of medics in the country. Good morning. It's coming out to 8 o'clock, 80719012600. When you open up the phone lines, when you have our guest in the studio, please call in 07120122600. Good morning. It's 8.
Sugar and spice and everything nice. Spice FM.
Spice up your life. Traffic.
All clear on Kiambu Road. Teke Teke is what is being used to describe that road today. But unfortunately now we have seen that things have no longer remained the same on Langata Road, and Jogo Road is now chocker blocked. We're not moving out of there right now. Matatus have clogged up everywhere on Outer Ring as well. And so Outer Ring, Jogo Road are causing us some serious problems right about now. We're trying to get off that road. Mombasa Road, not a problem. She's being a good girl today, as it were. Let's see how things change as we move along. For now, though, it's easy street, and we're able to move along as smoothly as we can for now. Any other trouble spots that we see, we'll let you know in a short while. Don't forget, you can call us 0719 012 600.
This is The Situation Room, the home of hard-hitting political commentary and penetrating insights about the state of the nation. This is a talk radio experience like no other. The Situation Room, a place for hard truths, debates, and elevated conversations. The Situation Room, witty, political, engaging, deep, controversial. In the room, we have Jerry Thorne, lawyer, political strategist, an insider in the corridors of power, ready to take on any side of the debate with her signature eloquence and grit. C.T. Muga, researcher, academic, seasoned political observer, a fountain of wisdom in these politically uncertain times. Ndu Oko, Nigerian by birth, Kenyan by choice, communications expert, Pan-Africanist, a truth seeker and believer in people power, and Eric Latin, agent provocateur, the man in the chair, seasoned journalist, news hound, a man who believes in punching up, not down. This is The Situation Room, the only way to start your day.
2 minutes after 8 o'clock. Good morning, and thank you very much for joining us. This is the Situation Room. It's Kenya's biggest conversation, This is Spice FM broadcasting in Nairobi 94.4. We're in Mombasa 87.9, in Kisumu 102.5, in Nakuru 96.0, 90.9 in Nyeri, 96.7 in Eldoret, 97.7 in Malindi. And we live stream this show every day, every morning between 6 a.m. and 10 a.m. on Spice FM KE, Facebook, Spice FM KE, YouTube, and www.spicefm.co.ke. The conversation happens on all our social media platforms. So our YouTube handle, our Facebook, what's that thing called? Twitter.
That one.
that thing. Yeah.
But okay.
Our Twitter handle is Spice FM KE. Please follow us. And the conversation of our hashtag, The Situation Room. In the room, of course. My name is Eric Latif. We have Nduoko. We have Jerry Thorne. We have CT Muga.
Every once in a while, Kenyans are treated to some sort of demonstration, and usually some union is behind it. Now, for the longest time, whenever we had issues that related to medical practitioners, it was treated as almost unethical. And then what came about was something very interesting, a union that actually encompassed medical caregivers and specifically doctors. So everything that fell under that umbrella now had a structure within which to actually air their grievances and also seek redress to things that they felt needed to be addressed, not just for the doctors, but also for the people whose mandate theirs was to take care of. We have with us today in the studio a very distinguished gentleman, a gentleman who has followed the footsteps of many people who have taken the line that he has. He has been incarcerated. He has been pushed around. He has felt the full wrath of the law in trying to fight for the rights of the people he represents. This is Dr. Ouma Oluga, who happens to be the man who is at the helm of the union that represents the medical practitioners in this country. Karibu sana daktari.
Asante.
Have I introduced you adequately?
Thank you.
Karibu sana.
Was that colorful enough?
Yeah, that's quite dramatic.
Dashing young gentleman too.
You've been in the trenches. You've come out stronger. Right. So
Let me begin by asking this simple question. What led to the formation of this particular union? What was the thinking behind it?
Wow. Two things. One is that this union actually existed from long time ago. It existed from 1972. That's the first time the name KMPDU was coined, and it was coined by veteran people. And if I told you their names right now, you'd be shocked. People like Dr. Gikonyo, the former Kibaki doctor, the very distinguished professors right now like J.A. Alwaj, who is, they were the first group. People like Dr. Nyikal, who is now in parliament. But there was the first group, Kamarogo.
Yes.
They were the first group who coined this name then. But the constitution of Kenya then did not allow doctors to form a union. So it was illegal. And myself, many of them went into police cells, many of them were incarcerated. And then 1981 again, 1994 was even bigger. In fact, in some of the magazines, there is on the front page, give us a union or give us nothing. That was the 1994 doctors. And in that particular year, 2/3, like 60% of all Kenyan doctors left the country because they could not be granted a union. And many of them went to Botswana, many of them went to South Africa, many of them crossed Lake Victoria to go to neighboring countries. Some of them went to the US, some of them went to UK. And many of the senior doctors who you see in those countries, that's the time that they left 25 years ago. And then the 2010 Constitution happened. The 2010 Constitution happened, and that was the hooray moment for doctors, because finally we could register a union. So we registered it in 2011, August. The second thing that I want to say is that all over the world, unions are growing only in the healthcare space. The reason is that it is only in healthcare that the commercialization of healthcare was not a problem before, but now it is a problem. This privatization, cost of healthcare, issues of labor are very new in this industry. Unlike people who work, for example, in factories or in companies where unions were there from long time ago, from the 1920s, healthcare is quite new. So you find the way the society used to treat nurses, the way the society used to treat doctors, it was very sacred. It was more of, very revered. Nearly the same way we treat priests, nearly the same way we treat priests and medicine men. But then when the commercialization started to come from the 1980s, and then now doctors were looked at more as labor, not as people who can treat us, then that is the reason also why unions are growing in the health sector. So we are lucky to have KMPDU because this is the structure through which government recognizes. We had KMA before, but KMA is registered as a society, so it cannot engage in labor engagements. It cannot collectively bargain. It is not legal for it to sue anyone in terms of issues of labor. So this is really the reason why KMPDU exists. So we are very lucky to have KMPDU. Maybe in a minute I'll go to what exactly we have achieved, and not for ourselves.
Actually, why don't you just go right in and tell us?
This is the minute.
Yes.
Yeah. So yes, and I think it's very important for our listeners to understand what KMPDU stands for. I'll make it very simple. If you have relatives somewhere in a village in Kenya, like myself, those relatives of yours would never ever be able to afford a doctor unless the government employs one and makes a doctor stay in the nearby facility. That is the simplest way KMPDU has assisted this country. In 2007, there was a cabinet memo, this was chaired by the president, that 7 out of 8 doctors that were leaving the university in Kenya were leaving the country. 7 out of 8. So there was this crisis of medical doctors' migration out of the country. In 2011, the then head of public service, Ambassador Mudaura, had a very nice proposal on how we can retain our doctors. But the government had never ever been able to retain doctors in public service, and they had never ever been able to retain doctors in Kenya for 50 years until KMPDU happened. In 2011, so KMPDU did this very nice proposal. It was a 13-point proposal to the government on how we can make sure that the mwananchi, the one who is most vulnerable, the one who would never ever see a doctor, never ever afford a private one, be able to have a doctor at the nearest health center or the nearest hospital. The only way is to employ, and the only way is to pay that doctor better. The only way is to make sure that that doctor works there. And this is what we did. So in 2011, unfortunately, you give these good proposals to government, you negotiate for 2 years, nothing happens. Then you know what happens? You have to push them. So we went on strike. And tremendous things happened. They employed more doctors then. But something that this country has never known, from 2011, we reversed the trend. So 7 out of 8 doctors were leaving the country. From 2011, 7 out of 8 doctors are retained in Kenya after graduation.
So we complete reversal. 7 out of 8 who were leaving, now 7 out of 8 stay.
So if you look at there's a WHO document that is calling it the countries in a crisis, countries in a crisis of health workforce. Kenya is one of them. In 7 years, or let me say 8 years, from 2011 to now, we, the union, have removed Kenya out of that list. Why? Because Kenya now has the highest retention of medical doctors in the whole world at 65%. Because every doctor that is now employed in the government stays in the government.
Of course, you've got to mention that the economy was also changing. So people might have been moving out because of the economy and better opportunities at the time. Of course, the brain drain maybe during Moy's era was a lot higher than during Kibaki's era. So it can't be discussed in isolation to everything else. The economy was also changing.
That's true.
Yeah.
That is true. Of course, it can't be in isolation to everything else. But for us, we want to look at it specifically from the way in which, for example, doctors were being treated, the way in which the market. Let's talk about the international market for doctors. The demand for doctors in other countries. Even right now, in fact, we are fighting the same issue because government is now finding itself in this situation where they think they have enough, but we still don't have enough. There are many Kenyans in Wajir, in Turkana, in Siaya, everywhere. Even here in Nairobi. Nairobi County, for example, has only 258 doctors that they have employed.
Against the demand of
government doctors. For a population of 5 million during the day, and in transit about 7 million people.
Yeah.
What's the recommendation per
So
person?
the recommendation per person, Nairobi County, if you do the WHO ratios 1 to 1,000, should have at least 7,000 doctors.
Right.
So they have 258, and then they have another 2,000 doctors, around 2,500 in the private sector. So even if you look at that number is still too low. So we still need to triple, multiply by 3 the number of doctors that we have. Many Kenyans go to, I would say, clinics. They are not seen by doctors. They complain about the services. They think they were treated by doctors, but they were never treated by doctors.
Who are those people who we find in the clinics?
Medical officers.
Right.
Yeah, we have a number of professionals in the health sector, and we're not blaming them because they're doing the best that they can do. For example, if you go to many areas in Nairobi, even very decent places like Kayole, and you look at the many clinics that are there, 99% of those clinics have 0 doctors. But those Kenyans think that they are being treated by doctors. This is what the union does to make sure that Kenyans really have access. And the only way is to really make sure that you really employ those doctors, whether in the private or the public sector, and we retain our doctors and we train them and we make sure that they are at par with the international standards.
Daktari, are you suggesting that medical practitioners who are not medical doctors or healthcare givers who are not medical doctors and who are licensed to treat, are you saying that the government did not think through this process of allowing them to have licensure?
Not necessarily that they did not think through. Governments all over the world like shortcuts. So we, as many other governments, because of the 1970s, the 1980s, we were not able to train doctors and to retain them. I've just told you about the history. So the medical school was just one, the University of Nairobi. And then in 1991, Moi University came. That was the second one. Now we have 10 medical schools. Now we are able to train our doctors. Now we are producing 1,000 every year. But because of the situation then, again, you've mentioned the Moi era, the Kenyatta era, Kenyatta one, they had to do something that responds to wananchi at that particular time. So what did they do? They created Kenya Medical Training Colleges. Wonderful ideas. So they did what we call mid-level trainings, mid-level professionals, and then we did not transition into the new era. And if we were to look at, for example, the people who are working class or middle class, partly this is why they find our care not to be standard, and they have to go to India
and so on.
because then we have not improved ourselves to that level where we could deal with complex cases. So we need to stop now doing the short gap measures and start looking at long-term solutions.
Who funds the union? How is the union funded?
The members.
So this money then essentially comes out of your pockets for training of doctors then that would be hired by government?
No. So basically we are a membership-based organization. So doctors pay a membership fee. Right now we have 7,200 members, and that is the highest in terms of percentage. We have 88% of all doctors are our members. So we are very privileged to be in that position where we really can speak for a lot of people. But that's not even the resource. The resource is the doctor themselves. But the most important thing is what I said, that we do this for wananchi. Personally, I am licensed to practice in America. I did my training here at Moi University, went to Nairobi University. I've had my master's. I'm a physician. I like to treat heart diseases. I did my exams for the what we call the United States medical level entry exams in 2012, and I passed, and I'm licensed to practice in America. I could go and make a lot of money, but who would treat my mother here?
So I'm just going to ask you about unionizing and the fact that there was restrictions previously, both legal but also a lot of resistance from an ethical perspective. So instead of me criticizing you for unionizing, you can tell me what are the pitfalls for you having this collective bargaining power, as opposed to me questioning you about it. What was the rationale behind not allowing unions?
There were two rationales then. One is the government reasoned that doctors were already in a job group that they considered as managers, and managers were not allowed to be in unions. But the second reason is actually the question of ethics and morals. So the world has grappled with this issue about it's an ethical dilemma, basically. And it's also a moral dilemma. The ethical dilemma is on the doctor, the moral dilemma is for the society.
Right.
Because people do not consider doctors to be people. Generally, doctors are considered as elites in many societies. You know, they aren't
and they're not.
They aren't the strugglers, you know, but they're not. So that also brings a big question from the society. Why should the person that we respect so much, that we entrust our health with, be on the streets? So that is a really big question. But the ethical issue is when you are on the street, then who takes care of the patient? And that is something that has been discussed. So there is the World Medical Association has a whole paper on physicians and strikes, and the World Health Organization also has a whole paper on that. And I think and thank you for inviting me, because we really need to engage with our wananchi so that they understand. So first and foremost, doctors are employees. They are employees. They are employees who have to go to work and have to earn a salary and have to commute and have to pay rent and have to buy food and have to pay school fees for their children and have to live the way every human being lives.
Sure.
And this is really the question. So yes, they have this ethical responsibility to respond to society in a way that the society trusts that you are safe, that you are the person who I can confide in my medical issues. But I'm also an employee who, if I'm not treated well, then I can also resign, I can die, I can be away. And that is also the same thing. Sometimes, if I am not employed, you will not even have me. So the answer is that when I'm away on a strike and I've given a notice, it's the same as if I did not exist, if the employer did not employ me for you.
Shouldn't you be selfless healers, and in striking you put patients in serious jeopardy? I'm sure you know that's the ethical conversation. But when you're first going into medicine, what is your drive? What is your objective? Because if it was money, perhaps it's not the career to have gone into. That's the debate on the other side.
Yes, that's the debate on the other side, and we really welcome that debate. The issue about in medicine we say that the patient in front of you is the most important patient. So when I'm away, you can't. I'm not responsible for the patient that I don't see.
Sure.
I'm responsible for the one in the room. And many times when and I mentioned the guidelines internationally, when doctors are on strike, we make it very, very clear: do not leave your patients unattended. So if you are in the vicinity of a hospital, you must attend to patients. Most of the time we organize for what is called emergency care. We do never tell the government because they take advantage of it. For example, in our last now
you've told them.
Now they know.
in our last strike at Kenyatta National Hospital, we did close the hospital, but and that's the first time in 100 years Kenyatta National Hospital was being closed. It's very shameful to say the least. And people would think that we would be proud of such kind of things. We are actually not, because it takes a lot of injury for a doctor to be on the street. Doctors want to be people who feel respected, whose voices are heard. By the time we are going on the street, it's already broken. It's broken. Our hearts are broken. We are also injured. We feel very painful that we must be on the streets because we know that there's someone who really needs us in the hospital. But we tell doctors, if you are in the hospital, you have your patients. You must attend to them. You must discharge them.
So the threshold for justification then for you to actually do that, to leave your patient and go on the streets, must be very high.
It's very high.
And what is that
Extremely
justification?
high.
What we see is that all these guys are asking for is more money. Just like everybody else who goes on strike. Teachers go on strike, money. Doctors go on strike, money. And if you're told by the government there's no money, and all of us know there's no
And
money.
nowadays, even more interesting. Nurses go on strike. Clinical
Money.
officers go on strike.
And nurses are allowed, were always allowed to have unions.
Nurses were
weren't they?
always allowed to have unions. So let me answer that question by giving you an example. 2 days ago, I was in Nyandarua County. So Nyandarua is one of these counties that have state-of-the-art machines that were given by the national government under this questionable
The leasing
MES, the leasing program. And they have this huge CT scan. They have a very good theater. Nyandarua had a doctor called a radiologist and then a surgeon, and they could not treat them well. So they were, to be very honest, they were paying them less than interns. So these doctors are in very high demand. They are very high demand here in Nairobi by the private hospitals. They are very in high demand elsewhere in the country. They are in high demand elsewhere
In
outside
other
of the
counties.
in other countries also, and in other counties. So these two doctors resigned. So they have their state-of-the-art machines lying idle. No one is there. This is how the union looks at it. For us, and to be very, 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 very honest, every single doctor in this country, including myself, could make pretty decent money not treating the public. We could make pretty decent money. Now look at those people in Nyandarua. There's no surgeon. There are needs, surgical needs. Where are those people going? They are dying at home because they can't come to the hospital. And sometimes when they come to the hospital, they are dying in the hospital. I was in Nyeri where the surgeon was complaining that he finds late referrals. Late referrals means people who have been sent from Nyandarua and Laikipia very late to Nyeri because maybe a general practitioner was trying to do conservative management because they do not have the skill to treat this patient. This patient ends up dying in Nyeri. The responsibility of the union is also to those people at home who must get a surgeon. And this discussion would never be had by the governors. They would never tell you that we don't have a surgeon. We need to spend money in employing a surgeon. For us as a union, the way we look at it is this. What level of pay, what level of treatment, what conditions do you need to have a surgeon in Nyandarua? Because the people of Nyandarua need a surgeon. Sometimes that requires a strike.
Could it be that you're out there locuming as opposed to working for government as you should be? You've been accused of that, haven't you? The fact that you've been employed by the government, but because you're looking for money or in order to make more money, you're using government's time to actually go out there into private practice and freelance, so to speak, in your profession. How much truth is there to that?
A lot of truth, a lot of truth, but not put in the correct way. So the number of doctors who are licensed so this what happens. Every doctor is registered, and then you are retained on the register. But there is what it's called part-time private practice. Part-time private practice means that I have the government job, but I am allowed to do what is called part-time private practice. This was in 1994, when doctors had left the country. President Moi thought that the best way to reward doctors and to retain doctors was not to restrict them to public places. So they introduced a special license where you agree with your employer to give you what is called authorization. So there are about 1,500 doctors who have both public and they are authorized by the same government
to work in private.
to work in private. Now, it is the government that authorizes you, and it is the same government that comes complaining. I think it's double standards.
I think
on the
there's-
government.
Their hours, for
Of course,
example.
no, exactly. I was going to say there's
Yes.
rules and regulations and a framework through which you have this license.
There is no rules
Now
and
it's-
regulations.
So
None
you
at
can
all.
work as many hours in the private practice and not turn up to work in the public
No,
sector.
there is your requirement. There is basically your requirement at the public sector, and many doctors surpass that. But if you find, for example, I'll give you a very good scenario. So you have one plastic surgeon. He's required at Aga Khan Hospital, he's required at Nairobi Hospital, and he's required also at Kenyatta National Hospital at the same time. So this is what happens because he goes to Aga Khan first, and sometimes it is late in the night. So someone has a hand that is has been cut by a machine, maybe accidentally in a factory, and this plastic surgeon has to come and fix this hand. This patient has been transferred from Kiambu to Kenyatta National Hospital. But this surgeon is also required because there's someone who has a breast issue that the plastic surgeon must fix at Aga Khan. All these people require the plastic surgeon. The government has licensed the plastic surgeon to practice in all these
To be an Aga Khan at that time.
What do you choose as a doctor?
Where the money is, that's what you've been choosing so far.
Thank you.
Is that ethical?
So
Now
why?
herein lies the question: how ethical is that? Should you not be selfless healers
It's-
if you're coming into this profession?
Both of those
They're patients.
They're all patients,
And
And
all
they're all
require
going to
service.
pay,
and
right?
they are all going to die, and they're all going to pay.
Okay, so if both are dying, you will choose the one where
Where you
you'll
get
make
more
some
money.
Not necessarily. During our CBA negotiations, we made it very clear that we wanted government to pay doctors so well, the professor, for example, that they only stay at Kenyatta National Hospital. Do you know the irony is the government refused?
They couldn't afford it, or why?
No, it's because they are the same
The
people.
professor is in the government.
The professor is not in the government. The professor runs a hospital
Private practice.
that is owned by someone in government.
I see. The point here. So
I don't know whether you get my
Could
point.
you say that again? Let's just go over that again.
In 2017, during our CBA negotiations, we made it very, very clear to the government that we are tired of being accused of what is called dual practice. Although dual practice is acceptable internationally, but we are tired of it. It's because they use it as what is it called? As an abusive tool to tell doctors, oh, you're just going to your private practices, which is actually not true. But we accept, okay, fine, let's say we are going to our private practices. Then let's do this then. You give me enough conditions so that I stay here in the public sector, so that I never go to that private
So
sector.
you also leverage on it. You could also abuse it, or be said to be
Yes,
to
so
abuse it as doctors.
No, we didn't. We just looked at, in many places in Turkey, in India, in the US, people just practice in one place. And by the way, those professors, they do not like running from one hospital to the other. They completely hate it.
So when
because-
you're doing this, it's purely for financial gain.
No.
When you're running from one hospital
No,
to
no, no.
another.
It's purely to help patients.
And these
the
patients
patient-
can't
Not
come to the
purely,
public
it's-
hospital?
The patient can't come to public hospital because the patients think that they are special, sorry to say, because the patient has gone to Nairobi hospital because they have a private insurance. But in Nairobi hospital, they do not have the specialist. The specialist is the same specialist at Kenyatta
Right,
National
and
Hospital.
interesting, and that's because of you doctors, because you're willing to go to the
It's
private
because
sector.
Nairobi-
if you refuse
it's because
and
Na-
you're stuck in the public sector, people would have to bring themselves.
It's
Nairobi's
because
paying better.
it's because Nairobi hospital exists.
It's
and
paying
because
better. It's purely for financial gain as a doctor.
Not
Or better
necessarily.
facility, better working condition.
Better facility, better working condition, same patient, same specialist. This is what we really have to do. What we have to do, and this is what the union really fights for. Let's train doctors. Let's train very many specialists. So, for example, this is when we push government and we tell government, what's your training budget? You put 2% of your healthcare budget into training doctors. We will have 30 plastic surgeons, so that you don't have to have one plastic surgeon who is
And
required at
demanding
Aga
for
Khan.
And then having to divide
Yes.
their time across
This is why the union exists. So the union exists for those patients at Kenyatta National Hospital, for those patients who must get
Although
a
if doctors refuse to go into private practice, patients would be forced to come to public hospitals, which would help fund them better.
I
because
already
people would be
mentioned.
paying into the
I already
public.
mentioned to you that when 2/3 of doctors left the country in 1994, President Moi thought, "How can I retain the few that I have? Let me allow them to be in the private sector."
One of the complaints that has been raised is that government doctors who work for the government, will actually defer treating you within the government hospital but refer you to their private clinics.
Not true.
We can answer this after the break. But how many people do you think died as a direct cause of your strike in 2017?
Government had statistics and they said people did not die.
All right.
But
you don't think you put anybody's lives into jeopardy?
But what do you
don't
think?
there was
What's your statistic?
We have done our own analysis. What we know is that the economy lost about 12 billion during the time that we were on strike.
How many lives?
A lot.
Was it worth the strike? Losing those lives?
The issue is not that. The issue is not about...
This is an issue, though.
The issue, and this I'll also give you an example.
But there's an issue you want to answer first.
There's an issue I want to answer first.
So let's first of all take a look at what's happening on the road. Let's have a traffic update. Well, we have in the hot seat in the Situation Room this morning, Ouma Oluga. Dr. Ouma Oluga is the Secretary General and CEO of the Kenya Medical Practitioners and Dentists Union. He's here. Of course, the first barrage of questions we've been asking is to justify the union's existence and the union's activities, especially in calling for strikes. And then, of course, we'll be looking at other factors that affect the medical practitioners across the country. This is the Situation Room. It's 27 minutes to 9 o'clock. Good morning.
Mature, intelligent talk every morning. Spice up yourself. Mornings
Things are not bad
done
enough on
right.
Road. We might
90.
have an accident in that area, so expect added hold up there. And it's right around your mobile turnoff, and so there's a turnoff getting into Langata proper, and that which allows you get downtown. And so because of that accident, things are definitely going to slow down. We had some issues along Uhuru Highway trying to get into the city centre, but that has been cleared up. Thank you very much to the police. Let's see what happens in a short while where we get to about 9 o'clock. Coming out of Westlands on Wayaki Way is not so bad either, and today has been a generally good day. Everybody's been behaving. The roads have been acting nicely towards us. Getting into the weekend where things have definitely slowed down. Traffic as well cannot be left out. 0719012600 is the number to call. See anything else that we need to know about this morning and share to keep you moving. We definitely will.
Mature, intelligent talk every morning. Spice up yourself. Mornings done right. 94.4 Spice FM,
As we
Nairobi.
looking into the traffic, I'd asked the question, or I had raised, this is something that has been in the public domain, that a feeling among the public that doctors will refer you to their clinics instead of treating in the public hospital. And you said categorically no. How do you measure this? How do you determine that this is not true?
Yeah, the way we do it is simple. In healthcare is very emotional. So there are very many things that can be used, and because the union has really been campaigning, and this is all over the world, not just in Kenya, many people, because they cannot provide healthcare to their people, the doctor is the cat that they want to hang. And this is very well calculated. It's all over the world. In America, in China right now, doctors are being shot. In India, in India actually, where Kenyans like to go, that's the place where the violence against doctors is the highest in the whole world. This is what happens. So basically, there is very little understanding, and especially, again, I'll come from our society. So the society invests very little in terms of trying to educate people on what you need to get services. For example, what are the requirements for me to get treated? So what happens is that you come and there is a doctor in the hospital. So this doctor wants to, let me use myself as an example. So you come and you have a problem. I can see your legs are swelling. I can see your blood pressure is high. I can say, maybe I want to check your eyes. Then I do not have the equipment to check your eye because the hospital does not have it. I do not have the machine to check your heart, which we call echo. I am the doctor. I know exactly what to do. I know what I need to test you for, but I don't have all of these things. Then what I will do is to tell you, I'm sorry, our hospital does not have all of these things, but these things can be done. And I know that they can be done elsewhere. So I send you, not because I want you to get better, but because you have been told by the politician that sasa hospitali yetu inafanya kazi, and as a Kenyan you believed the politician, but the politician did not tell you the truth. So they brought the doctor, but they did not bring the machines, they did not bring the diagnostics,
they didn't equip the doctor.
And they never equip the doctor. So I don't even have, even just the thing we put in our ears. There are several levels of it. So there is even a cardiology stethoscope that I was never given. So I, as a doctor, bought myself one that is cheap. I bought myself one for 10,000 that I can use, but I need a specific one to listen to your heart, which I can't. But I know, because I am trained to know
need this one.
that you need this one. So I'll send you.
So you'll send me to Oluga and Latif clinic.
Yes.
Where Oluga and Latif have bought this equipment.
I'll send you to Oluga and Latif, where Oluga and Latif have bought this equipment, or I'll send you to somewhere else where this equipment has been bought, even if it doesn't belong to me. Now, this is the point. You, as a patient, what would you rather do? What would you rather do? Because
bottom line, I want to get treated.
Yes.
All right.
But this the facility where you have come to cannot offer it. So what's the decision you want to make?
If really you were being faced with an ethical dilemma, it's not a dichotomy of choices. There's a lot of things you could do. You, as a doctor, could go to this hospital and not charge doctors' fees. If really you wanted to treat the patient,
it's not me who is going to.
The obstacles are the fact that there is no equipment. Let's say that is true. Going by your version, you cannot say it is because the patient needs treatment. Let's not put your ambitions and greed, sorry, for lack of a better word, as doctors, because wealth acquisition is also important to you. Clearly,
no. Most doctors don't own these things, and I think that is where the narrative is lost. So, for example, let's look at Kenyatta National Hospital. So you want a hormonal profile. Yeah, you have this issue with fertility and people want to do a hormonal profile. Lancet does it, and it is across Kenyatta National Hospital. Right. Lancet is not owned by a doctor working at Kenyatta National Hospital. Lancet is a global company, it's a South African company which is franchised in Kenya, and will send you to Lancet because you need it. And the where doctors have been, where the moral question, it's not really a moral question, it's emotional abuse of doctors, where people have thought that doctors own this equipment and they use it to campaign against you, and we don't. For example,
there no doctors who own hospitals and own this equipment, but also work in government?
There are doctors
and will send patients to their hospitals?
Negligible. In fact, I would want the country to do an assessment of every single place. Some of those equipments are very expensive.
Where the perception, I think, arises is, well, yes, so this particular facility is owned by a big organization that has invested heavily. But when I cross the street, tomorrow I'm going to find Dr. Ouma Oluga in this particular facility.
This is now.
So I will not be able to differentiate between Ouma Oluga of this facility and Ouma Oluga that I found at Kenyatta National Hospital last week.
And this is the problem why we must improve our public healthcare. And for us as a union, we are so clear. In fact, we are very, very clear about improving public healthcare. So we have this agreement we had with the government called the Musimi Task Force Report on how to equip public hospitals, on how to make sure doctors stay, because these things that we are discussing, we do not want to discuss them as a union. We want you to come to Kenyatta National Hospital, to Mbagathi Hospital, find the doctor, find the equipment. The doctor is paid well. The doctor does not have to leave. We've even talked about, by the way, interestingly, let me say this. In our CBA, we have about 40 working hours in which we enshrined. Again, the hospitals and basically the county governments have refused to implement it. You know why?
So
because
are we not
if they implement 40 working hours, it will show a lot of gaps. Okay. So they don't want to implement it because, number one, some use it as a manipulation so that they can call the doctor anytime. But some also, they don't want the gaps to be shown. For example, if the doctor were to be available there at Mbagathi, which they are, There would be a lot of gaps. You would actually see this is not working, that's not, and that's
so can we say that we don't have the presence then of doctors in public facilities because we are lacking medical infrastructure? Is that the reason why they're not there?
Doctors are there. I think what we are discussing is a very small problem, and it affects a very small part of the population. And to be very, very honest, the people who go to private, purely the people who depend on private practice in Kenya are 4%. About 35% do both. You start at a private doctor's clinic, you will end up at Kenyatta National Hospital. About 65% of our population is 100% public hospitals. They have absolutely no option. If you gave them even that form to go to Lancet or to go to Nairobi Hospital to do that, they would never do it. So this is the segment of the population that the union works for. So the many of us who can come and find Dr. Luga in a private place and complain, because I also went to Kenyatta and found him there. Yes, we work for you, but the one that we really care about is this one who comes to Kenyatta. And today, if you go to Kenyatta National Hospital, like I was in Nyeri also, you will find 1,000 patients lining. Those are the people we want to work for.
Dr. Luga, let me ask the question. How much time and resources does the union spend in getting the public to understand these things that you're outlining so clearly?
Yeah, I think we have done a poor job as doctors, and we have done a poor job in partnering with media. And we have also done a poor job in setting out the narrative that would actually make the mwananchi demand for better. So, and we are not an old organization, but also because we are coming from there's a heavy burden of poor perception, people get mistreated. There's a lot of personal problems, and sometimes this mistreatment, misdiagnosis is actually true. So there's also a very huge uphill task in terms of how to get our message out there. And this is why I think it's very important for you to invite me, but more importantly, I think as a union, to partner with media so that we get the correct information, because the truth is that Kenyans are really suffering.
People have said that devolution has actually made the life of the would-be patient worse.
True.
And that the union has done very little to change this. How true is this statement?
We have done a lot to change this. I've just told you the story of Nyandarua, where there's no surgeon. We went there and we were engaging with the county government and telling them, listen, the county government would never ever come on Spice FM to say that, by the way, we do not have a surgeon. What they would come is to sponsor a story or an advertisement to show that they have an equipment, but that equipment is not functional. So the people of Nyandarua are not benefiting.
So has devolution been useful to the health sector?
No.
Why?
Because of the devolution has not been useful for the health sector. I will look at it from the bigger reasons. So the bigger reasons of health equity. So health equity. One county does very well, one county does not do very well. It means that you are treating two sets of Kenyans very separately, yet these two sets of Kenyans pay the same taxes, are entitled to the same constitutional right to health. So this is what happens. So one county, for example, Kakamega, does their healthcare very well, Kisii, healthcare very well. And then some counties, healthcare is completely collapsed. So then it's like we have segregated groups of Kenyans. So health equity, bad for Kenya. And it's bad for Kenya because it also then increases what the health security in terms of outbreak of diseases. Right now, for the last 3 years, we've had these pockets of outbreaks of cholera. The last time cholera was in Kenya was in 1998. Cholera came back to Kenya through Tanzania after devolution because counties like Migori could not handle their healthcare. Counties like Busia could not handle their healthcare. So
they couldn't contain it.
They couldn't contain it. And then, once there's an outbreak of cholera in Migori, it gets to Nairobi.
So that's one reason.
That's
a strong reason.
One of the bigger reasons of the health equity. Another one where you say that devolution is not working for healthcare.
Another reason why devolution is not working for healthcare is what we call economies of scale and economies of impact. So you have this many counties, they are trying to spend their money. For example, a county would never have some counties may never have the need for a neurosurgeon. But people in that county, they're still border people who get accidents every day and they need a neurosurgeon. But the county says we don't need a neurosurgeon, which is not true. So if you look at economies of impact and economies of scale, it is only possible to plan for some national resources at the
Higher
national
level.
level, so that we say we need 30 neurosurgeons or 50 neurosurgeons as a country, not as a county, so that whether this neurosurgeon is based in Kiambu County or he's based in Nakuru, he will serve a whole region. This is not happening. So again, if you look at things like immunization, a county will go negotiate with a company, buy their vaccines substandard, because then we as a country did not look at how many children get born, how much vaccination do we need, can we purchase this as a country. Look at the issues of Panadol, and we did this study in 2015. One county buys a packet of Panadol at 1,300, another county buys a packet of Panadol at 300 shillings from different companies, different qualities. Some of them is what we call chalk, like they are just fake medicine. So it does not make any economic sense.
Is there no national
to divide,
oversight
yes,
body,
for
for
policy.
instance, the Ministry of Health, that ensures that there's a certain standard that each county must meet? Because it could actually work on the flip side as a very good way of ensuring competition, of ensuring leaders do what they want so they can be re-elected.
Unfortunately for healthcare, we cannot have anything called competition. There should never ever be competition. This is the reason why we should never have competition. When I get sick outside of this standard building, I will be taken to the
nearest
nearest
facility.
facility.
Absolutely.
Not the best facility.
when I
and
say-
I have this story to tell. Just 2 weeks ago, there was a man who was stuck in a hospital, and I would not mention the hospital. And this guy had stayed in the hospital for 1 week. He was a young man, 19 years old, who had got an accident, not talking. 1 week he was. So then one time, the doctors tried to get him to write. Then he wrote a phone number. This phone number that he wrote, the hospital really tried to call it. It was not going through. And then now looking at Truecaller, it happened that this phone number was a phone number for a governor. This was the son of a governor who had an accident and had stayed in a public facility for so long with the best insurance. When you get sick, when you get that accident, when I collapse, you will be taken to the nearest facility. So we must make sure that the standard of our healthcare is the same.
Across the board.
The issue about competition is a business
I
issue.
think-
So what's
Should
the role of
never
the
be
Ministry
I
of
think the
Health
word
then?
competition here is,
Yeah.
maybe I used the wrong terminology there. What I was saying is, at the moment, our health is a postcode lottery. So depending on where you are, you get different levels of care, which of course is care injustice. But on the flip side, devolution of healthcare services, if there was a standardized and a body, an oversight body to ensure that certain standards are met, certain drugs are bought, so it's not all generic, what the best is done, thereafter it could actually work to serve to improve the quality of healthcare, because you'd have counties almost competing against themselves, not necessarily just for the healthcare, but in terms of optics, to be known to have the best healthcare and so on. How can we go about ensuring that counties reach a certain minimum standard? Is there an oversight body? What is the role of the Ministry of Health?
Are you referring to
in
health
this?
tourism?
It could be also medical
Yeah.
tourism across counties.
Yeah, I mean, yes, and to be very honest, sometimes when we talk about devolution of health and we condemn it, it all looks gloomy. To be very honest, there are counties that have done very well. To be very, very honest. For example, if you go to Mombasa, the maternity hospital in the Coast General looks better than any private facility in that same county. So they have done very well. And in fact, I think they have almost taken all patients from all the private hospitals in Mombasa. So there are counties that have done very, very well. What I said is in terms of health equity. So you find 20 counties doing very well, and then 27 counties are not doing anything.
Yeah.
And also because counties have different priorities. If you are the governor of Nairobi, traffic is your priority, garbage is your priority, health is not your priority, but you have 7 million people who can also get sick,
Yeah.
on
any given day.
So that is why, to be very, very honest, what we call social services, education, healthcare, security must never, ever be
devolved.
left to political decisions at a county level. They must remain. For example, we cannot devolve the military.
Absolutely.
Healthcare is as important as the military.
If
It is
not,
the gateway to security.
Sure.
And right now we're talking about biosecurity, issues of Ebola. You've seen them, bioterrorism and all those kind of things. You cannot leave that. And that is really why we are saying that if we are to be very, very serious as a country, we cannot devolve
Is
healthcare.
there a
And
way you can have a hybrid in terms of...
Yes. Yes, and this is what
That's
happens
the
in many
solution?
countries. That's
Yeah.
the solution.
How would the universal healthcare program that it's currently being piloted, is it not?
It is.
How would it help in bringing what you're saying into reality?
The framework of the UHC in terms of the legislation, like what laws or what policies are we putting. So far, we don't have a UHC policy. So in terms of UHC, there are two things. One is either you are funding it via taxes or you are funding it via insurance. So we have not decided which one that we are going to.
What's the difference?
The difference is that when you are funding healthcare by taxes, every single Kenyan is entitled. So what they do is that the tax that you pay, a percentage of that tax goes to healthcare. And we know then that every single Kenyan will be entitled to the same level
Of healthcare.
of healthcare,
regardless of who you are.
regardless of who you are. That is what the union stands for. That is what we want for every single country.
And the
every single
other
citizen.
option, the insurance one.
The insurance one is basically, there are two also models of insurance. There's what we call the welfare insurance, or basically the social insurance, where the government can decide, okay, we want to pay for you the insurance. So if you can pay for yourself because you are employed, it's fine. We will make it mandatory and deduct it from you. But those who cannot pay, we will pay for them, so that at the end of the day, every Kenyan has an insurance. Okay. And then there is the other one where you simply regulate and say, okay, these are the insurance companies. This is what we will demand from insurance companies. You as a Kenyan, go buy for yourself. That is the worst form. So the welfare insurance or the social insurance also works a bit better. But the only difference is that then where you seek your healthcare and where I seek my healthcare, yet we pay for the same insurance, we don't get the same quality. Because you may be accessing, and this is what is happening right now, you have civil servants who are going to Nairobi Hospital, Aga Khan, and then you have same Kenyans paying same NHIF, but they are only condemned to Kenyatta National Hospital.
Right.
So the best way to do, especially in a poor country like ours, and I would use the word poor because I know that the people we speak for are the people who are really vulnerable, is the tax-based healthcare funding.
Dr. Luga, you've used the word here, condemned, to Kenyatta National Hospital. The perception in the public arena seems to be that Kenyatta National Hospital
Is the worst.
is a hospital whose quality is below that of the Aga Khan Nairobi Hospital. Is this really true?
No, it's not true. But I'm sorry I used the word condemned. I mean condemned in the terms of confined. So
This is the only place that you can
is
access.
the only
public.
place you can access public. Or you, let me use, you have only been allowed to access county hospitals.
Yeah.
And others can fly abroad, go to South Africa. Same insurance.
We have in the
Speaking
studio Dr. Omar Oluga. He's the Secretary General and CEO of the Kenya Medical Practitioners and Dentists Union. We'll be opening up the phone line shortly as he also grabs a sip of water. This is the Situation Room. It's 5 minutes to 9 o'clock. Good morning.
Mature, intelligent talk every morning. Spice up yourself. Mornings done right. 94.4 Spice FM, Nairobi.
Dr. Luga, I want to take us back to this issue of Kenyatta. Okay? If you were to grade hospitals in this country, which hospital would you say is the best, everything considered, in terms of equipment, in terms of personnel, in terms of service?
Kenyatta.
But why is it that the perception that Kenyatta is not? And what is it that makes Kenyatta the best hospital?
Because Kenyatta has the highest number of specialists anywhere in the sub-Saharan Africa, the highest number of specialists. Number two is that Kenyatta has also quite Kenyatta is a very good system, but for what I call elective, Kenyatta becomes a bad hospital because when many people go for emergency, like I want my care now, then it becomes difficult. And you know why it's difficult? It's because it's congested and because the whole country depends on Kenyatta.
It was not purposed for that. It was supposed to be a referral hospital.
It was supposed to be a referral hospital, but counties have made Kenyatta a dumping site. So what happened is that Machakos bought 70 ambulances, Kiambu bought 15 ambulances, Kakamega bought 30 ambulances.
They all drive to
and all they do is to transfer their patients to Kenyatta National Hospital.
Can we look at your most recent assertions or expressions in terms of what you want to do now when it comes to county governments? Because I think what you had said most recently is that you're actually going to sue the county governments because of the lack of the, establishment of the 2017 CBA. Where are we now with this one? What is this all about? What is the contention here now, apart from the CBA, or is it all enshrined in that?
Yeah. Again, I mentioned we have done a very poor job in terms of engaging with our listeners, the public, to really make them understand why the CBA is for them. And I mentioned two things. One is that the CBA has 9 articles in them. Only one of those articles talks about the doctor. The rest of the article talks about equipment in the hospital. It talks about staffing. Sometimes.
Could that have been strategic for you doctors in order to frame your requests without coming across as selfish individuals who should actually be selfless healers in the society?
We are citizens. And first and foremost, there is this famous speech I gave to the doctors. And I said, first and foremost, we are citizens and we must act as citizens of Kenya who are trying to make our country better. Then second, as doctors. But as doctors, this is also a profession that we love. It must also give us something back. It must give us a life back. It must pay us the way it pays other doctors in other countries.
Also, there's the conception, or clearly now misconception. Growing up, becoming a doctor, it was quite sort of glamorous, and it came with it wealth. In some countries, for instance, Cuba or even the UK, being a doctor does not connote money. It might be a respectable position in society, but it doesn't come with it's not synonymous with wealth. I think in Kenya we've had that for the longest. The richer people in the community, the more successful, respected people were doctors, let's say in the 70s and 80s when our society was forming. I think that might be the problem with our doctors at the moment, and that perhaps we're expecting to be rich when they were coming into this career, as opposed to them coming in and actually adhering to the Hippocratic Oath and remaining ethical to their call. So perhaps the calling is what has changed over the years. People are going into this profession because perhaps they see it as an opportunity to acquire wealth as opposed to heal the nation, so to speak.
Yeah, I wouldn't disagree with you completely, but I would also discourage doctors from doing that. And when I speak to young doctors, I always tell them, first and foremost, you exist because of the patient. And I think we need to come back to, and the union has started a training program where we are looking at patient communications, we're looking at dignity of the patient.
Because we're coming to the
like
top
you to
of
come
the
back and
hour.
answer my question.
Yeah.
And then we'll look at traffic and all. We have in the studio Dr. Omar Oluga. He's the Secretary General of KMPDU. If you've got any questions for him now, you can call in at 0719-012-600. That's 0719-012-600. Good morning. It's 9 o'clock.
Spice up your life. Traffic.
All right. Really nothing to report. Everything is looking good this morning, except for we had that small issue on Jogo Road where traffic was literally bumper to bumper heading towards the City Stadium roundabout. But apart from that, everything is okay. Even Thika Road today, as the minutes tick by, we didn't have much of an issue. Unless something happens between now and 10 o'clock, it's actually easy street today.
This is the Situation Room, the home of hard-hitting political commentary and penetrating insights about the state of the nation. This is a talk radio experience like no other. The Situation Room, a place for hard truths, debates, and elevated conversations. The Situation Room, witty, political, engaging, deep, controversial. In the room, we have Jerry Thorne, lawyer, political strategist, an insider in the corridors of power, ready to take on any side of the debate with her signature eloquence and grit. C.T. Muga, researcher, academic, seasoned political observer, a fountain of wisdom in these politically uncertain times. Ndu Oko, Nigerian by birth, Kenyan by choice, communications expert, Pan-Africanist, a truth seeker and believer in people power, and Eric Latin, agent provocateur, the man in the chair, seasoned journalist, news hound, a man who believes in punching up, not down. This is the Situation Room, the only way to start your day.
It's 2 minutes after 9 o'clock. The phone lines are now open, 0719 012 600. You've got any questions or comment to ask Dr. Omar Oluga, the Secretary General of KMPDU. Alan calling in from Nairobi. Good morning.
Good morning.
Good morning, Alan.
A quick one.
Yes.
In my view, this is part of the mess in our industrial relations system. Long time ago, we used to take this thing called strikes in essential services more carefully. And there's an important thing called protection of the innocent third party. If I'm lying in an hospital bed, I'm a third party. You are just agreeing with your employer, but don't I have rights to services? So I'm glad Oluga said that they are working on some issues, some ways of dealing with this innocent third-party problem. But I think the union has not come out and told us what they are doing. They don't have a good policy on the question of innocent third parties. Second point, I like the fact that he wants to move the union beyond negotiating for negotiating salaries. This union should be publishing position papers on the cost of health service, on the Indian problem. They should be taking position on some of these big issues, so that they're not just a bunch of guys
who are seeking after their own welfare.
See, and you know what, my friend, the way the industrial relations system has broken down. Today, doctors go on strike. Tomorrow, paramedics go on strike. The following day, nurses go on strike. We used to have a system where only workers go on strike. Not everybody. Today, we have systems where even professors. You have professors going on strike. So, Mr. Luga should not think that doctors are special. We have big problems in an industrial relations system.
Right.
Yeah. Because look, what if Kenya Power guys went on strike tomorrow and this whole place goes dark?
They do. Alan, thank you very much for all your questions.
Okay,
let's hear Dr. Oluga answering them.
Alan, I wanted to ask you a question.
He's off.
He's off. I wanted to ask him what he would say if the police went on strike.
It's worth asking. He can ponder over it.
Yes,
he
can ponder
not
over that.
reply.
In South Africa, the police have a union and they can go on strike. This is the point, and this is what every Kenyan should understand. As long as you have someone engaged as an employee, that employee can be out of work.
So where do we stop? The army can go on strike and put the whole country at in danger in case we're under attack?
2 weeks, is it 2 weeks ago? The day that the president of Ethiopia got the Nobel Peace Prize, there was an army on strike in Ethiopia.
Prime Minister.
The Prime Minister. So the whole issue is about governance, by the way. These issues, these are the issues Kenyans should be looking at when they elect their president, when they elect their MP, when they elect their governor. And these are the issues that should form national discussions, because if you have professors going on strike, doctors going on strike, nurses going on strike, teachers going on strike, there's a broken thing, and that broken thing is the way we dialogue with each other. That broken thing is the way we prioritize our resources. That broken thing is the way we govern our country.
Looking at the history of strikes that have been had, would you be able then to say that after each strike, because there's the reason why the strike was initiated in the first place, something having not been fulfilled and agreements not having been honored. Now, as a strike then takes place, and after the strike has been called off, do you then see a difference between now what was agreed having now been established? Do you see that the strikes have actually yielded
Borne fruit.
In
fruit?
healthcare, if we did not have KMPDU, and I'll say this again, right now we have in the public sector 5,000 doctors. In 2012, November 2011 to 2012, do you know how many doctors we had in the public sector?
No, tell us.
1,100. Kenyans, you would be dying without KMPDU.
So you have
And
4
this
times
is,
the number of
there's
doctors.
direct
And this is as a
correlation
result of the
between-
strikes. If you had
Yes.
not gone on strike, the communication would not have been.
There's
been set
evidence for that,
through.
Daktari? I mean,
There
that's
is
quite a strong
evidence for that.
acclamation, the proclamation that you're making there.
There is
There is evidence
for
that
that.
it is a
What-
direct
what-
result
what if
of
I
your
said-
Direct
not
result.
because of
That-
the government's health policies and
No,
things
which
like that.
health
Or,
policy?
Doctor, what if I said we just started producing more doctors?
Absolutely.
No.
You said there's
We-
been more
It
universities.
was
That's
part. It
because
was
of
part
you
of what
guys?
they pushed for,
It's
right?
part of
That's-
what we pushed for. It's part of the training. And right now,
Coincidence and causation.
we have a specialization problem. You see the way Kenyans are going to India? We are spending
As you come to answer that, I also have somebody else on hold. Let's just take their
Okay.
question and then let him go. Victor in Kisumu, good morning.
Morning to Eric.
Welcome to the Situation Room, and Dr. Oluga is here. Say hello to him.
Hello,
Hi.
Dr. Oluga.
Hello, how are you, Victor?
I'm fine. What a great perspective you have.
Victor,
I just wanted to-
unfortunately, Victor, we can't get you. I think something has happened to your line, and it happens a lot, Victor, when you call in. There's some interference on the line. Hopefully he's going to call back and we can get that. You were raising
Yes.
a point, something.
Yeah, so now we have the specialization problem. And this is the point. So there are Kenyans who are complaining that they cannot get the medical care they want here. We have issues of skills in terms of I am misdiagnosed, I am mistreated. But basically what it goes to is the level of specialists that we need is not responding to the diseases or the disease burden that we have. What the union is doing right now, we are on the table with the Ministry of Health right now, and we are saying we must train the specialists. You can't just keep importing them. We must have 400 people being trained every single year to
And we have the money to do this? Do we have the economic
we
muscle to
have
do
the
this?
money. We have Kenyatta National Hospital to do this. We have the referral hospitals to do that. We can equip them. We have the equipments that were brought by the MES that are lying idle. For example, in Nyandarua, you have the best radiology machine with no radiologists. So it is lying idle. It is not helping any patients, not training any doctor. You see? So we are wasting resources. So this is what the union is doing. We are saying we now must start. We have done a very good job in terms of trying to increase the number of doctors, and we want to still continue. By the way, every single Kenyan right now still do not have access to doctors, and we are still pushing the government to employ more. But we even want, as they employ more, we want more surgeons. In Nyeri, we only have one surgeon in Nyeri, serving like Kipia. You know, do you know how big these counties are? Like Kipia, Kirinyaga,
They're massive.
Nyeri. And then now we have UHC in Nyeri. You find 1,000 patients. If you find the list of people waiting for surgery, it takes 6 months because there is only one surgeon.
There's
So now
also the
we want
issue-
to produce more surgeons. Nyeri itself should have like 10 surgeons. And also if you have one surgeon, the probability of error is very high because who'd say that my skill as one person is the best? Who is checking on me? Because we in medicine, we have what is called the peer review. Sometimes we say the best tool to make a diagnosis is another doctor in the room who has seen that and done that and can tell you, Daktari, I think you're making a mistake.
An issue has been raised, Daktari, on and what you're referring to here, the quality of the doctors that we have. And let's maybe go back to the quality of training that we are getting. Doctors have come to a point where you go and you get diagnosed by a doctor. Everybody will tell you, get a second and third opinion. Why must we be doing this? I mean, you go to a garage and your mechanic tells you you need to change this part of the spark plugs. You don't go and ask a second mechanic. You actually believe him.
You go and find another quote.
Yeah, you just get another quote for the supplier, but you believe the issue that you need to change is the spark plugs. Daktari tells you this is what is ailing you. everybody will tell you, no, get a second and third opinion.
Yeah, it's because of the campaigns that we're having about the misdiagnosis and all of that. And so basically it's a country's problem. It's not a doctor's problem. But I would also say that we as a union are taking it very positively, by the way. One of the people who really encourages people to come out and say when they are not treated well and to seek second opinion is myself. And my last statement was that sometimes the best way to make a good diagnosis is another doctor in the room who has done that and seen that and can say, hey, you're making a mistake. But you find in many of our hospitals, private and public, you're only seeing one doctor who is perhaps very overwhelmed, who says that their opinion is the best, who trained them. If you go to many counties, our doctors are the best trained, but the best trained in terms of education. But in medicine, every 5 years, things change. The way we treated diabetes 5 years ago is not the way we treat diabetes right now. So after you leave university, a doctor becomes a doctor because of continuous training, not because they graduated with medicine.
Sure.
This is why we want our government and our hospitals to invest in what is called continuous medical education.
When you have
short
these,
trainings.
when you have these conversations and are saying, I mean, obviously laying down the foundation in the manner in which you have done now.
Yes.
When you have these conversations with those at government level who then will be responsible for implementing it, whether it comes to shelling out the funds for it or at least making an agreement on some level when now we move forward, what is the response that you get?
They say
whereby you have an agreement and
they
then you
say
get to the point
we
where it
agree
is
with
not
you,
happening.
Daktari, we don't have the money to do it.
Yes.
So do you we
Now,
don't have the money to do it on that point.
On that note, Daktari, what is it that the union, because everything you've discussed, it sounds good, it is good.
On paper.
No. It's probably even being implemented, it will take time. But this is curative. What is it that the union is doing toward the preventative aspects of healthcare?
Yeah, I mentioned right now we have started a very aggressive member education program, and it involves quite a lot of aspects. Part of the aspect, by the way, they say that between 5 to 15% of all people who go to hospital complain. So, and it is just the 15% that complain. And 15% looks like a lot of people. But
it is a lot of people.
It is a lot of people. But there's the 85% that were treated well that do not talk. Now, what we are doing to address...
didn't bother to complain, so they weren't treated well. There's that statistic.
Yeah, there's that also. But many people, really, if they go and you ask them, they will tell you the truth, because this is healthcare. So we are looking at how do we address this. And one of the components is communication, patient communication. Do you know that it is only in healthcare where we do not have customer care training?
Well, you're telling us. Why don't you?
We don't have, because the way in which the system was designed that it's just you and your doctor, but your doctor just studied medicine. He was not trained. And this is very important. For example, we had a very simple case last week where someone has a lump in the breast, and this is someone who doesn't speak English.
Right.
And they are told by the doctor that we want to do a biopsy, but then they say that tutachukua nyama kidogo kwa matiti, tuende tupi. And then, they start getting mad because then they're like,
why?
Unataka kuchukua nyama? It sounds so bad.
Yeah.
But you see, simple things like, how do I communicate this? These are the things that we really, really need in healthcare, so that patients feel dignified,
do you
patients
not
feel
have
respected.
to communicate things like empathy, sympathy, emotional intelligence?
Empathy is there. Empathy is there and all of that.
How would you translate
how
that?
do I translate it in words?
You have to be trained.
You have to be trained. And we are we looking at simple... In best hospitals, I have gone to... If you're looking at, for example, the joint accreditations for hospitals, that's healthcare indices, patient communication right now and patient safety is a very key component of training. So beyond how to teach me to treat diabetes, you must also train me on how do I translate this test to the patient. And right now, for those of us that have specialized, we are trained. Like for me, I'm trained in patient counseling, we're trained in that. But how many Kenyan doctors have specialized? So we also cannot condemn them.
But how many of them are even willing to be trained?
No. We are doing it as a union. Every single doctor is willing. And I think one of the best things that we have, this country is really, really lucky. The kind of doctors that we are having, were the best. These were the people that you celebrated during your KCP and KCSE.
They're the A students.
They
So
are
maybe
the
they're
A students.
technically
They are
good, but they lack these,
They are the most disciplined.
skills.
And if they are technically
So the
good,
soft skills is what we're
if they are technically good, then we can also make them
emotionally intelligent.
Yes.
Sorry, not that they're not, but
I'll
can
open up the phone
enhance.
lines again. We keep bridging between this and that. 0719 012 600. That's 0719 012 600. We have Dr. Omar Oluga. He's the Secretary General of the Kenya Medical Practitioners and Dentists Union. These are the guys who came on and then doctors started going on strike. And he's explaining why this is happening.
Doctors had been going on strike before them, Eric.
But we just didn't see them, so organized as a unit. Now, I'll be opening up the phone lines to hear what you have to ask. And then as we continue with this conversation, Doc, I hope we can keep you to 10 o'clock. There'll be issues that also will come up. For example, you talked about 7 out of 8 doctors leaving the country, and now 7 out of 8 doctors staying. So that means 1 out of every 8 doctors is actually still leaving. And there's an issue that Njeri has been discussing on this show often, and she also, I'm sure, will bring it up. The issue of patriotism, because doctors are very critical. We have spent so much money to train you guys, and then the issue of patriotism. Do you stay with us? Do you leave? Where does your loyalty lie? Of course, we'll discuss that. Let me pick up this call. Good morning, Rono.
Good morning, Eric and team.
Good morning.
Good morning.
Good morning, good Daktari.
Good morning, Eric.
Rono.
Yes.
Yes.
Rono, yeah. First of all, thank you for accepting to field questions for us. I'll ask you 3 questions. One, what is your position on the imported doctors, the Cuban doctors? 2, I understand where you are approaching this from, in the sense that you are doing it as a union. But given the complexity of medical care and medical services in the country, and the image people have of unions, they are totally like faith we have. It becomes very hard to accept an intellectual like you, because agitating on the street.
Number 3.
Isn't there a better way? Don't you think you can have something more acceptable than activism on the street? The third one is, what does the union have to say about alternative medical care? The herbalist in the village and the for lack of a better name,
Muganga wa mitishamba.
That is the herbalist. Yes. The other one, the one who prays a lot.
The Mjawi.
Oh.
yeah, that one. But okay. Lastly, to Njeri and City, the challenge we have in the medical service provision is actually something that cuts across every other service entity in the country.
Yes.
Lack of adequate numbers in terms of personnel, inadequate equipment, a loop-sided funding approach. Probably you'd be more sensitive to this than just badgering a good old doctor.
Actually, we haven't started yet.
Thank you, Rono, for protecting me.
All right, start with this number 1 question.
Yeah, I think we had a position on the Cuban doctors. Cuba is a very good country in terms of their healthcare, but their healthcare is very preventive. It is not curative. So, and we made it very clear that what our government was doing was not right. If they wanted to bring specialists, Cuba was not the place to bring specialists from, because they don't see complex diseases. They prevent all of them. Here we see very complex diseases. So a Kenyan doctor who has been doing dialysis is likely to be more experienced than a Cuban doctor because of the number of dialysis that they have done. So we made this very clear, and we said also that doctors respect each other all over the world. In fact, I'm very privileged to be the global co-chair for Health Workers for All Coalition, and we generally have collegiality and we accept each other. And we said we will accept the Cuban doctors, but we will still tell our government that this was not the right thing to do. We have 5 universities right now that are training family medicine specialists. So there was no reason why our government would spend 2 billion shillings to take 50 doctors to Cuba when Aga Khan, Maseno University, Kenyatta University, and Kabarak are training family medicine specialist. So I think there is a bit of self-hate in the country. I've also seen they're importing pilots. I've seen we give all our work to contractors who are abroad, and then our youth graduate as engineers,
Even
and then they
investigations
are
on a simple
jobless.
murder case
I think
bring
we
in
must
FBI.
start to love ourselves as a country and to start saying, okay, so if our doctors lack this skill, how do we get the skill? And that's the question we must answer. And I think as young people, and I'll speak for young people for a moment, I think we must put our government to task, because if you're an engineer and you're trained as an engineer, but the SGR is given to contractors from China, how well will you ever train to be an engineer that in 20 years' time, in 10 years' time, you have enough experience to help
serve
this
the country.
So we are not doing ourselves a favor by bringing people without training our own, and we find our engineers are jobless now, our doctors are now jobless, our pilots are jobless. I think we have a big problem with the way we perceive ourselves as a country, the way we acquire skills. If it is a discipline problem, let's solve the discipline problem.
Question number 2. Isn't there a better way? That's what Rona was asking. Isn't there a better way for intellectuals like you to agitate without, going to the streets?
I would believe that there is. But I would also like to Rono to do a bit of history in terms of engagement of governments all over the world, whether it's the USA, whether it's Russia, whether it's China, whether it's right now there are protests in Hong Kong. Is it that China doesn't have a better government? So the way to engage governments all over the world, and again this must be a message to our youth and young people, my friend. Serikali sio rafiki yako. Kama unataka kuingia serikali ama kufanya kitu that government will, we engage all the time. For example, you just asked me, we sit with the Ministry of Health, we agree on nearly everything.
And then
we
so
put
it's
it
lip
down
service,
on paper.
that's what you're saying. Yeah.
It's lip service because it's competition
do
for
people even
resources.
sign?
They even sign, by the way.
They
They even
attend the
sign and
meetings.
they tell you, oh, this is a very brilliant idea. But the way to move public service, there's one of the consultancy firms called McKinsey Quarterly have done a very good paper on public service management, and one of the things they say in public service management, creating crisis is the best way to bring solutions. This is worldwide.
There was a third question from Rona. You remember the question?
Yeah, I wrote the question down, and the question was alternative medical care.
Yes.
We have in the Health Act now, there is alternative medicine. I think basically two things I want to say. Not every herbal medicine is safe. The fact that something is herbal does not mean, or natural does not mean it is safe. So it still has to go through testing to look at the impurities, to look at the poison in it and everything. And this is what the Kenyan government is trying to do now. And we as a union are supporting it. The second thing is that you as a individual need to seek care when you're sick first and foremost. And there are a lot of approved natural remedies, or basically herbal remedies or alternative medicine remedies. We have the Ayurveda, you have the chiropractors, you have all of this. And I think there is this space for everyone. But in this country, I think the regulation is still quite weak. So many people, they take the chemical medicine or the therapeutic medicine, they mix with some herbal thing, and then they give people in doses that are not safe, and this is what is happening. So people are drinking a lot of steroids out there, and you feel better and you think that you're being treated, and then in 2 years, 3 years down the line, you come with kidney problems and the beribimit. So not every natural thing is safe.
Speaking of natural things, what's your take on marijuana and its medicinal purposes, and should it be legalized if you believe that it has medicinal qualities?
I believe the smile tells you everything.
For things like
So tell us the benefits.
By the way, I let me interest. I have never seen marijuana.
Have you not? Have you not smoked it?
Never.
Okay.
I've never smoked. I've
never
never
seen.
seen. So
Never seen the
when I
plant.
say this,
But you understand the chemical components and the effect they can have on the body.
I'm trained. Yeah, the effect they can have on the body. I think that there's a lot of research on the issues of of marijuana, its side effects and its medicinal effects.
Mhm.
And I think there is some ongoing research. Still not, there's still no, in medicine, until something has what's called randomized clinical trials. That means that it's multi-center, multi-country. So you have several countries that are doing the same research, same product, same conditions of patients, so that we know the outcome. So
You have something conclusive.
So there's nothing conclusive, but there's some literature pointing towards medicinal values in marijuana, also treatments of headaches and those kind of things. And there are people that are trying them. Some places, there are many states, for example, in the US, that have legalized marijuana for recreational. For recreational, not for medicinal. So in terms of medicinal, I think it's still work in progress.
I have another call on the line.
Yeah,
He's been on hold. This is Graham calling from Nakuru. Good morning, Graham.
Good morning.
Welcome to the situation room, and thank you for holding.
Okay, I would like to help the doctor.
Oh, you want to? Okay.
You're his colleague? You're a doctor?
No. I'm not a medic. Actually, I'm a loss prevention officer. It's a new business concept, and we are doing very well. Anyway, trade unionism is a disease. Na ni ugonjwa ambao umepitwa na wakati. That doctor should know that. Secondly, if he takes or he goes through the Employment and Labor Relations Act, it heavily borrowed from a jurisdiction that was going was adopting an outsourcing way of doing business, and that's where the MPs faltered. So nowadays, in that Labor Relations Act, the issue of union or trade unions, it doesn't work. The only option is labor outsourcing, and that's where we are headed for. Thank you. Daktari akufikirie hiyo mzuri sana.
Could I ask you a question, please?
Yes.
Are you suggesting that industrial action in and of itself is useless?
No, it's not useless. What I'm saying is, you see, policies, they have a lifespan and they expire. So the trade union policy that was there in the former regime of labor unionism and Labor and Employment Act, when they enacted a new Labor Relations Act, it borrowed heavily from a regime that was doing and was almost going an outsourcing way because of the success stories elsewhere. Because abroad, the outsourcing way, it has been proved to be working.
Thank you very
And
much,
that's where
Graham.
many governments are going. Thank you.
Asante, Graham.
Yes, I think Graham, well, I don't know.
I think the point he was trying to make, I did understand him, is that the laws that we've borrowed are not applicable to our situation. They were heavily based on the fact that there was a lot of outsourcing, which is not the case here. So maybe perhaps not as relevant. I think that's the point he was trying to make.
I don't think so. The Labor Relations Act that we have is 2007. In fact, today there's a parliamentary committee meeting, which I will be heading to after this, to looking at how to amend it. And for them, of course, they want to amend it to outlaw strikes and those kind of things. But well, I don't think people striked in 1994 when there was no constitution, when they were not backed, and you can never ever stop human progress. It will never work. I mean, humans will always collect themselves and they will always push for their agenda, even if they don't have a union. And so I don't think laws should be restrictive, but I think also outsourcing, as he's mentioning, should be done for services that are not core. Like, for example, Kenyatta National Hospital exists to provide medical services. So you cannot outsource for expertise that provide medical services. That's your core. You outsource for things that are not your core. For example, you can outsource cleaning, you can outsource accounting because it's not your core business. But medical service is your core business. So I think Graham needs to maybe also look at where outsourcing is applicable. In the medical sector, doctors, nurses, Laboratory people, you can't outsource them. That's your core business.
The conversation continues right here in the Situation Room. This is Kenya's biggest conversation. On the hot seat this morning is Dr. Ouma Oluga, Secretary General and CEO of the Kenya Medical Practitioners and Dentists Union. Good morning. It's 9:30.
Spice and everything nice. Alright, okay.
Spice up your life.
Nope.
Traffic.
Better situations looking around the city from Mombasa Road to Langata Road, coming out of Ngong Road and also from Thika Road today. It's fantastic. Wouldn't it be great if it happened this way each and every day? But we're just going to enjoy it while we can today, aren't we? We had a bit of an issue coming off of Langata Road a few minutes ago, but not so bad right now. People have basically gotten where they're going to and left room for those who are going to wake up a little bit later. So nothing so much to report right now, and hope it carries out like that through the day. 0719012600 is the number to call should you find anything out of the ordinary or something that you would like us to share about concerning traffic, of course.
Mature, intelligent talk every morning. Spice up yourself. Mornings done right. 94.4 Spice FM, Nairobi.
29 minutes to 10 o'clock. Thank you for joining us. This is the Situation Room. It's Kenya's biggest conversation. Dr. Ouma Oluga, Secretary General, KMPDU.
Dr. Oluga, can this country actually afford the sort of healthcare platform that we have, the curative one? Can we actually afford it?
Yes, and the thing is not to compare ourselves with another country in terms of resources, is to use what we have in the best way we have. I have sometimes suggested to government that let's look at where do we want to be in 10 years' time and make sure that every single year we are doing what gets us there. The challenge that we have is that this country has very good plans, and we have them on paper, Vision 2030 and all of this, and we want to put medical tourism hubs. But when our public servants or governments, or politicians, and even us citizens, and even us unionists, when we wake up every single day, what does your diary look like? Does your diary look like you are heading in the direction of the plan that you have? It's about what am I doing today, tomorrow, this month, this year, that gets me to 2030. So this is really the challenge that we have, and it's an implementation problem. So we have this talk issue where people come, they say beautiful things. Oluga comes here on Spice and he says beautiful things. When he goes back, is the union doing what it's supposed to do to sort out the misdiagnosis problem or the training? What am I doing? Have I lined up a training next month, and in December next week? And so this is really the challenge. So yes, we can get the medical care that we want. We can build the healthcare system that we want, but it takes a lot of dedication. It takes a lot of integrity. It takes a lot of what is called common good, and this common good is what is lacking in government.
Well, you mentioned that there's when we asked the question, you mentioned that when you have these conversations or when you make these agreements, they say, look, we don't have the money.
Yeah.
But then you've just told us, the money is available. To get these things done. So where is the disconnect between saying it's not there and seeing that it is there?
For example, this is how we will look at it. So we will say, okay, you have 38 billion Kenya shillings. Now it's 52 billion Kenya shillings to buy equipment, to buy CT scans, to buy all these things, right? Fine. Let's look for where do you need to put this 52 billion or 38 billion. So you buy for Nyandarua a CT scan and a machine worth 200 million, and Nyandarua has 15 doctors that in total their whole salary in a year is about 30 million. Yeah. So you give them a machine worth 200 million that is lying idle, that they are not using. But you see where this 200 million, would we have put it in training? This, you see? So yes, let's say Kiambu needed the machine, and it's okay for Kiambu to have the machine because, for example, they already have the doctor, they already have the people who are going to use it, they have the patients there. So this is really it's a prioritization problem.
Can I ask something?
It's a prioritization problem.
Who are you speaking to? Who is the audience when you're saying you ask where they're going to put the money? At a national level, this is government dispersing money to devolved health facilities? Or does the money get handed over to the governor and it's down to him to then decide?
It doesn't get overhanded to the governor.
Right.
Sometimes
so there's
also,
a control. There's control at a national level.
Yes. So we are talking to the national level. We always engage with the Ministry of Health. One of the things that our union does very well, and I think the public have even seen, we even attempt, and successfully we have done so, to even engage with the presidency. And we do this with a lot of respect because we want to get our ideas to the table. You know, we just don't want to talk and riot and do all this. We want to engage. And I wish that we were seen as citizens who are trying to help our country. Yes, we could be unionist, and maybe people have a perception problem with unionists. But at the core, is Dr. Luga Kenyan? Does he have ideas that can build this country? Can these ideas be implemented? And if they can't be implemented, then what is the alternative idea that can be implemented? This is really the engagement that we always want to have. During ours, I'll go back to the CBA issue because she mentioned that we want to sue. And yes, we want to sue. One of the things that we experienced so much is that the government kept telling us, no, we can't do this. No, we can't do this. Then we asked them, what do you want to do? And they didn't have an answer. So we went and brought 7 different proposals. 7 different proposals. This is 7 different ways.
Options.
We can
choose one.
We can help you. Please choose one. Yes. And of course, I think because of also a bit of embarrassment and all this, we decided to come to compromise, and they chose one, and they looked at it, they negotiated and they amended it, and then we signed it. And it is registered in court. So actually, lack of implementation of it is also contempt of court. But we look at all these issues and they just keep saying no. So they want to buy CT scans, for example, 37 CT scans. Then we ask them, how many radiologists do you have in the country
to operate these scans?
To operate these scans. They don't have. We were been touring Central, so we were in Nyeri. They have a very beautiful CT scan machine, Megascope, one of the best 64 slice machine for those maybe who understand. They have one radiologist, one. And he doesn't even have support staff. So, you know, we look at this and you have 100 patients waiting. And, you know, the things that machine can do are marvelous. The things that people go to India can be done there in Nyeri. But when you have one person who is not having support staff, he does not have radiographers to help him. There are not 2 of them. And even himself, he needs better skills of what we call intervention, so that we do intervention, you know, like those biopsies that are done with a very small needle, so that you don't have this huge scars of surgery. Those things can be done there. Do they need those skills? These are the things we talk about. So when we say train this doctor, we're not just talking about out of the blues. We know the service is needed. We know there are patients who are waiting. We know people can benefit. And this is why we are talking about prioritization. But beyond prioritization is also common good. So there are many people in public service who do not have any common good. So they go there and they look at how within these 5 years can I make myself 1 billion. These people like Oluga just wanatusumbua tu, wanapika tu kelele.
Kelele, ni watu wa makelele all the
time. But I think at the core of, and I mentioned, and I keep saying this not because we want to be special. Actually, we are not special. And I like a caller who said that doctors are not special. In fact, doctors are not special. And if doctors are not special, treat them like ordinary people, pay them better, you know, just treat them like employees. Don't complain when they are not there, you see? So they are not special. So for me, if I were to look for money, I would actually go and practice in America where I am licensed to practice, or even here in Kenya I would open my private practice. I wouldn't bother coming to Spice and going to Nyeri and doing all these things and getting arrested. Who wants to do that?
So you're advocating for the greater good of society.
I have my village, and I'll say this very passionately. I grew up in a very humble background, and in my own village for 50 years, for 50 something years we've never seen a doctor until one was employed in 2017, and we pushed the county. So
you didn't visit your village before 2017?
No. I grew up in that village.
No, it was
yes. So I
as a doctor, had you
yes.
not visited your village for them?
But I was never
seen a
employed
doctor?
by the government to
Right.
go there and treat people. Were those people not dying for those 50, 60 years?
Let's talk about
So this is
cancer.
really what we want to do.
You know, Daktari, I'm going back to something I've mentioned. One of the things that has actually been in the media for a long time is just the sheer costs, the waste aside, of the equipment that the government has insisted on leasing. Now we're talking about equipment that is being bought. Essentially, we are trying to ensure that we cure people who are sick. I'm going back to my question again. If you take a cost-benefit analysis, if you may, which would be cheaper? To prevent people from falling sick in the first place so you don't actually have to treat them in such large numbers, or to simply allow the system that we have to go on so we keep having to invest in treating them?
They say prevention is better than cure. So I think we really need to do much more. And this is also something that is important to say. Thank you for bringing it up. In healthcare, there are many things that feed into healthcare that are not healthcare. The roads, for example, the foods that we eat, and I've seen now there's a good focus on Kenya Bureau of Standards, because there are a lot of things that we consume that make us sick, that have, for example, aflatoxin causes a lot of liver cancer, a lot of liver cancer. So if we do not look at the maize that we eat and how they are stored and all of that, then we'll have a liver cancer. So yes, you will be having a problem of treatment at the end, but you
those
would
are
have
prevention
prevented.
issue.
So the roads, the traffic, the mental issues versus how long do you stay in traffic? You know, these are very important things. The environment that we have, the air that we breathe, water. So there's a lot of things we have to be as a country. All of us must do our job, whether you are in agriculture. For example, the antibiotics that are given to chicken and cows. When you go and you are eating your very nice salon steak, you know, you are consuming antibiotics. When you get sick, then the doctor gives you the antibiotics. You're already resistant to it because you have been eating salon steak every day. So these are the really nice issues about prevention. But prevention in itself is also not cheap. We have to really invest in professionals in all sectors. The buildings that we have, are they healthy buildings? So it's all so much. So healthcare in terms of curative is actually a small bit about health.
The bigger part is the other one. So and brings me back to the question that a caller had called and asked you: why doesn't the union take up positions on such matters? For example, even publishing up papers and position papers and saying this is what, as a union, we stand for more engagement or more investment on curative healthcare than preventative preventative healthcare than curative, for example.
Yeah, I think we are taking that as a challenge. One of the reasons is that we are a relatively young union, just 8 years old, but an 8-year-old child is no longer that young. So we are taking this very seriously as a challenge. So we'll be doing those position papers, but also it requires quite a bit of resources. And ours is member-based, so member-based resources sometimes is limited. So we will also be engaging with even members of the public to take up positions. Right now, you've seen we have taken a position on the issue of PPP at Kenyatta National Hospital, where we have also gone to court, because we do not think that this will improve the whole hospital, and we do not think that the vulnerable Kenyans who depend on Kenyatta National Hospital would be prioritized when another private hospital is built, because it will just be for those who can afford, not for that mother who is right now lining up at Kenyatta National Hospital and has waited for 3 months to be seen by a cancer doctor.
It could, of course, inject some money into the system as well by bringing in the private sector. So those paying could actually end up paying for those who can't afford it, like the mother you're talking about. That is the rationale, of course, of the government.
That is the rationale of the government, but that is an assumption that, number one, the hospital will make profit. And number two is they are assuming that by the time they take over the hospital, if you build a hospital now and within 30 years you give it back to me, it's a shell. I will need to inject a lot of more capital to equip it. So we have those issues.
Now, I want to ask you a question about medical negligence and sort of the avenues that people have for redress and the involvement of KMP DB. Oh God, it's a
DB,
mouthful.
yeah.
That one. Of course, medical negligence. It can happen anywhere. When it's considered negligence, it's because of recklessness or what have you. But there's a reputation that the doctors have where they're unwilling to hold other doctors accountable, and there's been accusations that the processes that KMPDB. No.
Are you talking about the union now or the board?
No, the board.
The
The
board,
board. I'm
okay.
not talking about the union.
Yes.
I'm talking about the board. But it's accused of having very lengthy processes, very opaque processes. It's apparently independent, but it doesn't serve citizens who felt they've been either, unfairly treated by hospitals, of course, have suffered losses or deaths and so on, unless it was somebody prominent. I think there was a senator's wife or somebody's wife who died, Wairimo, and the board acted efficiently. But generally speaking, the sentiment has been that doctors are not willing to hold one another accountable. They're very defensive of fellow doctors, and so very few negligence cases actually come to light, and people rarely get compensation. Would you agree with that statement?
Yeah, I think to be very, very honest, we as doctors also have an issue with the board or the council. Sometimes we think that they are not acting fast enough, and this is part of what has gone on in the public. So it erodes trust because people get either mistreated or misdiagnosed, and then when they come to the board, the answers are not coming as fast as they would want to. It spills to the media, and then what we call a few rotten potatoes makes all potatoes look bad. So this is also a big problem that doctors themselves have with the council, because they would want the council to act as fast so that there is trust in the healthcare system, there is trust in the health providers. So those are big issues, and we are trying to propose that instead of the council they have what is called a professional inquiry committee or a PIC committee that is supposed to sit with the...
Is it made up of doctors?
It is made up of doctors.
Is there a conflict there? This is what I'm getting at. Doctors would be defending themselves.
So it's mixed. So they invite doctors, they invite some people from, for example, the Kenya Human Rights Commission, they invite lawyers. So it's a really mixed committee. Now, what we are trying to propose is that even before that committee, there is a peer review mechanism, and a peer review mechanism can easily be anchored within the associations. For example, if this was a case of an obstetrics treatment that went and the way it was not intended, you can actually have the Kenya Obstetrics Gynecological Society sit and first review, is this the standard way to treat someone? And then this would feed into that committee so that the committee is not taking so much time.
But aren't those doctors likely to say, yes, they would have done the same thing in the same situation in order to protect their colleague?
I think this is also what I need to tell people. Negligence in itself is not just a term. Negligence is a diagnosis of itself, and it is a diagnosis of professional inquiry. So I, as a doctor, and you're a doctor, and you're a doctor, we have to look at it and say, in the circumstances, in this hospital, in this system, this is the best decision that should have been made. Then that becomes negligence.
I understand. And herein lies the problem.
Yes.
What I'm saying is, because it's other doctors, it's other people in your profession whom are actually the ones to make that decision as to whether they would have done the same thing. Now, that creates scope for doctors to protect each other, because they will always say, yes, I would have done the same thing given exactly the same situation. So nobody ever wins. You have to look at the reasonable man. So take away the doctor.
But it comes
you
from
can
here.
bring in a reasonable man.
What he's saying is, it comes from the peers, the doctors, and then it goes to the council, the
no,
committee.
but you see, the doctors,
and then
what
the committee
they'll do, so the doctors are advising the council. My contention is, when you have doctors who are the ones deciding as to whether what was done, which was ended up with some negligence or some harm or loss to somebody to whom you had a duty of care, you then get other doctors to decide whether, given the same situation and the same circumstances, they would have acted in the same way. Now, those doctors will protect their colleague. That is my contention.
I agree with you in terms of the conflict, but there is no way to cure the conflict.
There is.
because
This is what I'm suggesting. You
Okay.
can bring in what we would call the reasonable man, so that we take away the doctors, so that they're not defending themselves, because that's what happen. That's what's happening in the profession.
in the UK, they have what is called the medical tribunal. So the GMC, which is the General Medical Council, the equivalent of our board, has also what is called the medical tribunal. So in the medical tribunal, they have 3 doctors and 3 people who are not doctors. And what they do is that they look at what the General Medical Council has already determined and said, okay, maybe this was the correct way. And then they now look at society factors. Okay, even if it was the correct way, was there still harm? Is there still room for compensation? Now, that is not negligence. Those are called errors. So there are also system errors.
An error is negligence in law. It would fall under the
not
same.
necessarily. Negligence means that I omitted to do something which I am professionally,
or you were reckless about it.
I'm professionally bound to
care.
do.
Yeah.
I'm professionally bound to do. I neglected to do something, either by omission or commission. An error means that I had the best intention
but I
to
made a
treat
mistake.
you. No, I did not make a mistake. I treated you in the best way.
No, negligence
but
doesn't mean you
But
intended.
something happened beyond my control.
Was
Yes.
it reasonably
Yes.
foreseeable?
Okay.
What
Okay.
happened was
Yes.
reasonably foreseeable, then it's negligence. So it's negligence doesn't have to have intention. So you can make a mistake, but you didn't intend to leave the scissors in the woman's stomach.
Yeah, that's no, that of course is professional error. You know, that's what I'm talking about. So then there is what is within the mandate of the doctor. So there is, okay, we were doing this procedure and then we left a gauze in there. That is professional. That is the individual. But then there are so many errors that happen that people term as negligence, but they are simply...
That is negligence. To leave scissors in my stomach
that's
is
what I'm
medical
saying.
negligence.
Of course, that one I agree with you.
Okay.
That one I think anywhere in the world it would be
Right.
found like that.
Okay.
Yeah, including here in Kenya. I think those are the simpler cases.
And then the error one would be?
So the error one would be, we treated you, you came to this hospital, we had the theater space that we had and the equipments that we had. This is the best care that we would have given you.
So I would sue the hospital as opposed to the doctor, because it was a systematic...
Let's first of all understand
systematic
the error.
negligence.
Yes.
The error
So you would sue the hospital, but sometimes the hospital is not a public hospital or the hospital is a private hospital.
In the event that what happened, for
Yeah.
example,
Yeah.
in
Where
the
is the
event that
error?
what happened, would this error then now occur? Under these circumstances, when
A very-
with what had been presented to me,
Yeah.
what happened then that we would now have a situation of suit?
You see, like one of the very good examples, 2 examples I would want to give that have been very, very public. In 2015, we had this gentleman, Alex Madaga, may his soul rest in peace, who went to Kenyatta National Hospital, waited for 18 hours to be admitted in the ICU. He really required the ICU. The ICU was full. You can't unplug someone else who is there.
Plug someone else.
Yes, the theaters are all full. You can't take him to theater immediately because after theater he will need the ICU. So he's waiting for 18 hours and he passed on. That's a system error.
That's where the error
But it's
comes
still
in.
negligence in terms of from a legal perspective.
It's then it is.
we can call it, we can sue the hospital,
No,
not
you
the
can
individual
sue the
doctor.
state.
The state,
You-
absolutely. The
yes,
hospital
so-
is owned by the state, yes.
Yes, so you can.
Yeah.
And actually, Kenyatta National Hospital was sued, and they have declined to pay. And I agree fully with Kenyatta National Hospital because you can't blame me for not having ICU beds. You can sue, and those are what we call public interest suits that would make our government prioritize funding for
So
health.
it's the government that should be sued here, the state,
yes.
to ensure that there are more
The
facilities.
second,
Absolutely,
the
yeah.
second case that really was in the public domain, and I think people interpreted it the way they wanted, was the issue at Kenyatta National Hospital where the wrong patient was taken to theatre.
Yes.
System errors. And I know people are like, oh, as a doctor, you need to identify. No, but Kenyatta National Hospital does not have identification. Both of these patients are not talking. Nurses change duties. They are all labels from casualty. You go. The doctor in theatre is not the doctor in the ward.
The error is resultant.
So
I think maybe the
it's
terminology you're using, because error sounds like mistake. Now, if we start accepting that mistakes can be made, we take away the whole notion of negligence. Negligence
No,
is to say, yes, there was a mistake. Whose fault was it?
Negligence
But
is that
Jerry, remember
my
this is-
treatment, the treatment I
When it's
give
a system,
you.
it's an error.
No, okay,
When
but
it's
it's
an
still
individual-
negligence on part of the
No,
system. Okay, you're terming it differently.
When
And
it's
when I
an
take you to
individual-
court, it will be negligence on part of either the government or because they have a duty of care and they haven't lived up
I
to
think
it. So it
understand
falls.
you're using terminology that doctors understand differently
Mm.
from the
Oh,
way
yes.
lawyers
The
will.
lawyers
Lawyers
understand
are
it,
doing
yes.
Yes.
Yeah.
So in
Because
their
an
profession,
error,
they
if you
call
said
it
to me
error.
an error, there's very little culpability there. But
In fact, that's exactly what I'm meaning, that there's little culpability
Mm.
because
for an
then-
individual,
Yeah,
perhaps.
yeah.
But for a state or a system, there's absolute culpability. And at the head of that system is an individual.
Yes.
So that's how you would take it up as negligence still.
But in terms of, I was talking about professional
The
negligence,
professional
like
negligence.
at my capability as a doctor, I did something that I am obligated as a doctor to do. I harmed you, whether willfully or unwillfully. I harmed you. That is professional.
Doc, we have 4 minutes to the end of the show, the end of the week as well for us. I'd like us to conclude with, so we know that the government has been piloting the universal health care, the universal health coverage. Is it care or coverage? UHC, right? So universal health coverage across the 4 counties. And you mentioned that, first of all, we're implementing this without a policy, but it's a pilot phase. What are your views on this so far, on what has been rolled out, the successes or failures and the challenges that you see?
Yeah, I think one of the things that we really are lucky for, and I hope that we take advantage of, is the President's declaration of UHC. Political commitment to UHC is a very, very key ingredient of success of any UHC all over the world. And I think it was right that he was awarded by the AU for this. I think this is really right, because it's a really bold step. But beneath that bold step, we really need a lot of technical action to achieve. And I'm saying UHC because there's a lot of talk about care versus coverage. What we would love to talk about is care, but basically we're just looking at population coverage with the specific certain services. And for us as a union, we really welcomed this and we really supported it. Now, the only challenge that we have is that the UHC is a lot of talk and very little action. So you go to Nyeri, Kisumu, Isiolo, Machakos, and yes, people have really gone to the hospitals. The numbers have increased by 50-40%. Same doctors, same nurses, same medicines, same equipment. So zero investment in the facilities, and this is really what we are talking about. So if we really care for our people, and we know that they would come, and I went to Nyeri, they have done a fantastic job, but that's not the story everywhere. So we need to also invest across the system. The healthcare is what we call a system. So they are building blocks. I think we know that there's human resource, there's equipment, there's the way information flows. So we need to invest everywhere. So we have invested in a lot of talk and a lot of campaigns to bring people into the hospital, but we have not invested in the hospital. We have not invested in the workers.
Why do you think this is?
Partly it's a funding problem, but also partly it's what I mentioned before, that many things are usually viewed as as procurement, and this is UHC is a very good project. I'm just hoping that the president will not allow people to hijack it and make it another procurement thing.
Can we afford it as an emerging economy?
UHC is not it's not, for example, what UHC is to Japan shouldn't be what UHC is to Kenya.
Right.
So yes, there is a way in which we can afford it, and that's what I said, that we can plan it and say this is our priority right now is to employ more doctors or more nurses, or our priority right now is to make sure that hospitals have enough drugs, and then every single year we are doing something that is improving the system. That's how to achieve UHC.
What about
Thank
the
you very
necessity
much,
of
Dr. Ari, for
seeing-
coming. I think we're coming to the end of the show. Asante sana for coming. Your closing remarks as your parting shot. Talk to your members.
Yeah. So
members are members of the public.
Yes, thank you very much for that. For us, we really want to engage members of the public, and Kenyans are really suffering. We see these people every single day. They line up in hospitals. They have no voice. They don't know their MCA. They don't know their governor. They don't know their MP. All that they know is the person in front of them who is giving them care. And that is the nurse, that is the doctor, that's the clinical officer. We want to appeal to all citizens to really support our cause to make public health care what it should be for every citizen.
Asante sana. Closing remarks for the week, CT Muga?
Let the discussion
continue.
Thank you.
Jerry?
Looking forward to the weekend and the politics that will play out with the anti-BBI gang, as they call them, meeting the president and so on, the rallies that we'll see. And I'll be here on Monday with my crystal ball.
Ndu.
Kitaeleweka.
By Monday, by end of day today. Thank you very much for joining us this week, 6 to 10 a.m. My name is Eric Latif. We have CT Muga and Jerry Thorne and Nduoko. And of course, this morning we've been having Dr. Uma Oluga, who's a KMPDU Secretary General. Of course, between now and 3 o'clock, Spice Soul, and then Spice Drive with Monique, 3 to 7 o'clock. Of course, join her there. She takes you home. And then Adults in the Room, Eric, Emmanuel, and Barbara Mbaka will be with you today from 7 to 10. Good morning.
Spice up your life. Spice up your life.